A very good morning to one and all present here. Thank you for coming. I extend a warm welcome to all the Pathology, Gastroenterology, Pharmaceuticals Conference. I am Dr. Junu Rajan, working in Ahalya Hospital, Musafa. I'm a specialist anatomic and clinical pathologist. I'm the lab director, head of the department, and quality manager of the hospital. Utilitarian Conference Gathering offers a wide range of events, meetings, conferences, workshops, and symposiums. They have a dedicated team who are aimed at acquiring the technologies, adopting the knowledge of business needs, and accelerating with best ideas and strategies. Utilitarian Conference Gathering is a pioneer in the area of event management, collaboration. We are a full-service event provider specializing in the field of medical, clinical, healthcare, life sciences, pharma, and environmental science for academic and industrial sectors. We stand out distinctively from our competitors for our commitment to quality, round-the-clock service, and unmatched price. They are able to provide you with the best event meeting experience under one roof. UCG conferences make sure that you as a client choose the most appropriate event. And thank you all for finding time in your busy schedule to be here today. Today marks a major activity in the brief existence of the UCG conference, a moment we are interacting, sharing experiences, and reflecting on various areas. 12th EPUCG 2022 is a remarkable event that brings together professors, researchers, and students in the 12th Emirates Pathology and Digital Pathology Utilitarian Conference, making the conference a perfect platform to share the experience, foster collaborations across industry and academia, and evaluate the emerging technologies across the globe. We cordially welcome all of you to join us and witness advance in this field together. The conference has attracted delegates who have come all over the world, across the continents, and the subjects of the conference is surely of global importance. UCG and I thank you all the individuals and organizations who have worked to make this conference a grand success. And finally, I would like to extend my appreciation to the participants of this conference. We hope you enjoyed the conference and all participants will contribute to our professional development and relationship. We will have a workshop on Dream Medical Supply Company. Just want to emphasize that speech timing for the keynote speakers will be 40 minutes. Speech timing for the speakers will be 25 minutes. The poster timing will be 15 minutes and the workshop timing will be 40 minutes. The CME CPD certification and presentation certificate for online attendees will be provided on December 27, 2022. Once again, it will be on December 27, 2022. Now I take the immense pleasure of introducing the keynote speakers at this 12th Emirates Pathology and Digital Pathology Utilitarian Conference Summit Program on December 21 to 24, 2022. Dr. Subho Nanavati from the Happy Sapiens Dental, Texas, USA. Professor Hani Mewar from the University of Arkansas for Medical Sciences. Dr. Luba Al-Qureshi, C. Paradigm Diagnostic Informatics. Dr. Michael Redsky, Honorable Associate Professor at the University College London. Dr. Zeev Leifer from the Leifer Institute of Molecular and Digital Pathology. Mr. Bernard Gauthier, Global Product Owner, Gen Medicine, Digital Healthcare. Thank you all once again. We'll now begin the session. So let's start with our first speaker, Assistant Professor Dua F. Abu Kwisi from Jordan. She's passing a stage to deliver the speech on the comparison of histopathologic and ultrastructural features of Wilson disease in pediatric and adult patients. Over to you, Doctor. Okay, thank you for the introduction. My name is Dr. Dua Abtaish. I'm assistant professor at the You can start. You can give your right. Okay. My name is Dr. Dua Abtaish, and I'm an assistant professor at the Hashemite University in Jordan. I'm going to present a study that was conducted during my clinical fellowship at University of Toronto, and it's still this study still was continuous. So just a brief introduction. I did my MBBS in Jordan and pathology residency in Jordan, and then I had a GI liver pathology fellowship at the University of Toronto, and now I'm assistant professor at the Hashemite University. Briefly talking about Wilson disease. It's also called hepatolenticular degeneration. It's an autosomal recessive disorder affecting 1 out of 3,000 people. So as we can see in the image, Wilson disease usually affects, it's a multi-organ disease that leads to toxic levels of copper accumulation in the body. So we can see like the liver here is cirrhotic. There is a Kayser-Fleischer rings, which is like copper deposition in the iris of the eye. And that's also copper deposition in the brain. And that's a picture for an MRI that shows a panda giant sign that's typical for the Wilson disease. So then again, Wilson disease, we have accumulation of toxic levels of copper in tissue, organs, mainly their liver, brain, eye, and other organs, of course. So what really happens in Wilson disease? So we can see on the left, that's a normal. And in the normal, we have copper granules that comes in the portal vein from the sinusoid. The copper granules, they're usually in the hepatocytes. They go to the Golgi apparatus, and then from the Golgi complex, most of it goes inside vesicles or small lysosomes, and it's excreted through the bile duct. So most of the copper normally is excreted into the bile, while others are combined to apocytoplasmin and apocytoplasmin. Six of them are to the apocytoplasmin. They form the cytoplasmin that is in blood. Well, as in Wilson disease, what happens is the ATP7 protein on the Golgi complex, which absorbs the copper into the Golgi complex, is mutated. So the copper does not go inside the Golgi. And what happens is there's toxic accumulation of copper inside the hepatocytes. Copper is not excreted into bile, and copper also does not bind to apocytoplasmin and does not form cytoplasmin. So looking at this picture, we can know that people with Wilson disease will have toxic copper accumulation. They will have low cytoplasmin, and that will affect the hepatocytes and cause liver injury, as well as toxic accumulation in the body. Wilson disease patients, they have genetic mutation in ATP7B that causes defective in biliary excretion of copper. So you'll say, okay, so we can diagnose Wilson disease by genetic. However, that's not an easy case because there is more than 600 pathogenic variants of ATP7 mutations that were diagnosed in Wilson disease. So genetic is not always easy to diagnose it. So as we said, Wilson disease is an disorder of copper metabolism that results in toxic accumulation of copper. It might present, the toxic accumulation, of course, will cause, as we said, eye problems, CNS problems. People might present with psychological problems. There might be hemolysis due to the copper toxic in the blood that might affect RBCs and cause Coombs negative hemolytic anemia. There will be sometimes arthritis. There will be liver injury in the form of acute hepatitis, and we'll talk about it today, and might end with cirrhosis. Well, as it might also affect the cardiac and renal, and that's due to ATP7. It's mainly in the liver. However, this receptor is also present in other organs.
So Wilson disease can present at any age. The youngest in the literature is 3 years old, and the eldest was 70 years old. The average age was usually in the young, 13 years old, but it's rarely symptomatic before the age of 5. And some people have like psychological presentation for psychiatric presentations for Wilson. Others had a hepatic presentation, but the hepatic presentation was found as the first clinical manifestation in 40 to 60% of Wilson disease patients, mainly in the pediatrics. So pediatric patients mainly present with a hepatic presentation, hepatic injury in Wilson disease. So how is Wilson diagnosed, or what is a workup for Wilson disease? You can see here first, it depends on 3 things, which are the presence of KF rates, ceruloplasmin is low, and copper urine excretion is high. Once 3 of them are present, that's the easiest or case scenario, that if 3 are present, then the diagnosis of Wilson disease is established. However, if one of the 3 were affected, for example, KF is absent, or ceruloplasmin is high, and it's worth noting that ceruloplasmin is acute phase reactant, so that sometimes it can be high. Or if the 24 urine copper is low, one of these, in these cases, which is not perfect, life is not always perfect. So in these cases, liver biopsy will be required. So what we do is not only liver biopsy, we also do a copper quantification, or which is here. So if clinical signs and non-invasive tests did not reach a definitive diagnosis, a liver biopsy and a copper quantification would be required. What is copper quantification? It's they take a dry weight and they count how much copper inside it. So it's hepatic. If the hepatic copper content was more than 250 micrograms per dry weight, that's considered the best Wilson disease biochemical study. So once they take the core to send it for histology, they also should be sent for copper quantification. The problem with the copper quantification that it's not present at all centers. That's number 1. Number 2, that copper can be heterogeneous. It's not distributed evenly inside the liver. So it might give false negative results or underestimated in 20% of cases. So in our case, we'll talk about what is the histological findings when we receive the liver, and that's our study. On histology, what was reported in the literature that Wilson disease can present with varied non-specific patterns, mainly NAFLD, which is an umbrella including steatohepatitis and steatosis, and also hepatitis, or an autoimmune-like picture, was also reported, parenchymal necrosis or advanced fibrosis cirrhosis. So all these patterns are not specific. If Wilson is not in our mind, we'll miss it. And regarding our study or our experience, electron microscopy was a very valuable diagnostic approach for Wilson disease. So the picture here, we can see that this looks like a chronic hepatitis with portal inflammation and interface activity, which is reminiscent of what we see in AIH or autoimmune hepatitis. The other one is steatohepatitis with macrovesicular steatosis. So how did we conduct the study? The methods and the study design, it was a retrospective cohort study. There was 51 patients included. The age ranged from 3 to 52 years. We had 37 pediatric cases, and we have 14 adult patients. The pediatric was less or equal to 18 years old, while as the adults were more than 18 years old, including 23 males pediatrics, 14 females pediatrics, and 9 adult males and 5 adult females. Wilson disease was clinically confirmed in all these patients. Any treated patient who might alter the histology appearances was excluded. The hepatic content or copper content was more than 250 micrograms per gram dry weight for all these patients. What we did, that we got the archived slides for H&E trichrome, and the copper or rhodonine stain. And it was reviewed by 3 expert pathologists. Also, the archived electron microscopy images were available in 29 pediatric patients and in 6 adult patients. So these were also reviewed. The aim of this study was to assess and evaluate the histological and ultrastructural findings in pediatric and adult Wilson disease patients, to compare the findings and to highlight the essential role of electron microscopy in diagnosing Wilson disease. So going to our results. As we said, our patients' age ranged from 3 to 52. Positive family history was identified in 59% and 50% of pediatric and adult patients respectively, and that's comparable to what we have in the literature. There's 57% reported in the literature to have positive family history. Genetic testing was not available for all of them. However, Wilson disease was found to be confirmed genetically in 22 pediatrics and only 3 adults. The body mass index, we tried to find it because, like, we're talking about steatohepatitis as a picture. However, it wasn't present only for 7 adult patients, and 3 of them had a BMI above 30. So first, we assessed the histological patterns, which were fibrosis, stage 3 and 4, fibrosis stage 1 and 2, which is mild. We assessed if there is no fibrosis, also the patterns of steatohepatitis, steatosis, active/chronic hepatitis, cholestasis, and copper stain if it was positive on rhodonine, and the last one was glycogenated nuclei. So statistics was used chi-square test or a simple Fisher exact test, and p-values less than 0.05 were considered significant. Summary of the findings: steatohepatitis was significantly found in pediatric patients, 68% in pediatric versus 21% in adults. Steatosis or inactive steatosis was mainly finding in the adults, whereas hepatitis was only found in 4 out of 14 adults in comparison to 1 out of 37 pediatrics. So steatohepatitis was more in the pediatrics, while as steatosis or inactive steatosis was more in the adults. Fibrosis was more in the adult patients. Like, logically, adults will grow up, and in the active steatohepatitis will turn to fibrosis. So, however, there was no significant difference between the adults and pediatrics. Active chronic hepatitis in total, it was significantly more in adults than in pediatrics. In total, we had 10% of cases, adult and pediatrics, had an acute chronic hepatitis. The picture was reminiscent to what we see in autoimmune hepatitis, and the pediatrics even showed more than 30% plasma cells. So it was like a typical AIH pattern. However, it turned to be Wilson disease. Regarding rhodonine stain, like, you would think, okay, it's a Wilson disease, there's copper accumulation, so rhodonine would be positive. However, that's not the case. In our study, 35% only, or 1/3 of the cases showed positive rhodonine stain. And that was also comparable what the finding is in literature. It's the same percentage. Absence of stainable copper then does not exclude the presence of Wilson disease, especially on a needle core biopsy. And why? Because the copper distribution might not be even. The other thing to keep in mind that cirrhosis of any etiology can also show 2 times the normal hepatic copper content. So any cirrhosis with positive copper stain does not mean that there is overload of copper. Any cirrhosis of any etiology can show positive rhodonine periportal staining. So, summary of our histological findings. The histological findings were similar to the histology described in the literature, which are mimicking non-alcoholic steatohepatitis and AIH, which is autoimmune hepatitis, and including steatosis, steatohepatitis, chronic active hepatitis, glycogenated nuclei, variable degree of fibrosis. So this is a pattern what's described in the literature. It was also found in our study. We found that steatosis, steatohepatitis was the commonest histological finding, followed by advanced fibrosis and the presence of glycogenated nuclei. And then going to the electron microscopy, as we said, we didn't find a lot in our patients. So 29 out of the 37 pediatrics had archived EM, while as the adults, we only found 6 patients who have archived EM. So in the electron microscopy, we studied the presence of mitochondrial pleomorphism, dilated tip of Christie, fat droplets, paracrystalline inclusions, membrane duplication, and dense matrix. So all of these are finding in the mitochondria. And the statistics was the same. Fat droplets was 100% in both pediatrics and adults. Mitochondrial pleomorphism was almost found in 94% in both adults and pediatrics. 100% of adults showed mitochondrial pleomorphism, and most of the pediatrics showed mitochondrial pleomorphism. What reaches the differences between adults and pediatrics were that dilated tips of Christie were finding that is mainly seen significantly in pediatrics. Paracrystalline inclusion was mainly seen in adults. 0 out of 29 showed paracrystalline inclusions in the pediatrics. So these two findings were the statistical differences between adults and pediatrics. So in picture A and B, we can notice that the mitochondrial is pleomorphic. There's like different shapes and different sizes, which is abnormal. And the arrow in number A is the dilated tips of Christie. Picture number C, that is the paracrystalline inclusions that are found in the mitochondria. And D, the arrows are pointing for fat droplets. So, okay, we said on histology, like, how can I know the difference between adults and pediatrics? The EM pictures was really attributed to the age. We said it might be attributed to the fibrosis, since the fibrosis was more in adults versus pediatrics. So we switched and we compared the fibrosis, low stage fibrosis and high stage fibrosis, and all the EM changes. None of them reached any statistical difference. So our conclusion was that the EM findings were suggesting that these findings are mostly age-related. Our electron microscopy study had several limitations. First, the number of the patients that had available EM images was low, particularly for adults. We had only 6, comparable to 29 in pediatrics. None of our cases had a normal light microscopy appearance, so we can't use the EM to say like this is a first finding on the liver. The last one, that none of the 5 cases who presented with hepatic pattern had an available archived EM. So the EM was done mainly on the steatohepatitis and steatosis pattern. That explains why do we have 100% steatosis on the EM. Another study was done by our group, and it tried to describe the EM findings, the pediatric Wilson, compared to controls with similar presentations like NAFLD and AIH. So what we found, comparing EM findings in Wilson disease in pediatrics and in AIH pediatrics and in NAFLD pediatrics. So this study was mainly on pediatrics. They found that mitochondrial pleomorphism, dilated tips of Christie, membrane duplication, and dense matrix are significantly seen in Wilson disease patients compared to pediatrics who had AIH or pediatrics who had NAFLD. And the conclusion was also structural findings of mitochondrial abnormalities was very important to distinguish between Wilson disease from the other mimickers, which are mainly autoimmune hepatitis and NAFLD. In Wilson disease in the pediatric, the dilated tips of Christie had a sensitivity of 91% and specificity of 86% among all the EM other features. So our conclusion was that on histology, always consider Wilson disease in pediatrics who present with unexplained steatohepatitis, in adults who present with unexplained advanced fibrosis. EM plays a very essential role in the diagnostic workup of Wilson disease. Therefore, appropriate tissue triaging is very crucial in both pediatrics and adult liver biopsies. These are the references. And I'm happy to take any questions. Yes.
It was a nice presentation, Dr. Goa.
Thank you.
Well, I am a pathologist, so I have a question relating to pathology. How do you differentiate between NFLD and Wilson's steatosis? And moreover, you also find cases of steatohepatitis. So, do you have any method to differentiate between these two?
Okay, thank you for your question. So in pediatrics, always steatohepatitis, Wilson should be in the differential. So whatever I encounter in histology as steatohepatitis, the differential diagnosis listed is like metabolic disorders. However, it's rare in pediatrics. So, and Wilson disease and drugs are there. So steatohepatitis in pediatrics is usually a sign for an underlying metabolic disease, mainly Wilson. So once it's suggested, the pediatrician, once they see it on the differential, they will work up for the ceruloplasmin, the 24-hour urine copper, and they will do the other clinical workup, which is, so like, as we said, Wilson disease is not like a diagnostic only in histology, it's overall clinical correlation with pathological findings. However, in adults, it's rare. So if there is an unexplained fibrosis and you don't know how to explain that, if there's a history of hemolytic anemia, there's a family history of Wilson, there's psychological clinical presentations, all of these, yes, they should toward the thoughts to Wilson. And again, even in adults, we put the last differential in any report that we put metabolic disorders, medications, and Wilson disease.
Yeah, right. So whenever we see fat, we consider all these things.
Yes. Yes. Yes.
The mortality rate, ma'am.
It depends on the severity of Wilson disease. Like there's more than 600 pathogenic mutations, and it depends how much severe the Wilson disease, how much severe the copper toxicity, how much the patient is compliant on the chelation therapy. Like the exact percentage of the mortality, I'm not really sure about, but I know like it depends on all these factors. Like some patients even can live with Wilson disease without doing any extra procedure. So other patients, they need they will go through a transplant. Okay, thank you so much.
Thank you, Dr. Dua. It was an excellent, crystal clear presentation. It's a token of knowledge to you. Thank you so much. Now I would like to invite our next poster presentation, Dr. Lujaim Al Sahman from Saudi Arabia, to present her speech on suture thread incisional biopsy of oral tissues, a case report of a unique technique. She'll be presenting online.
Good morning, everyone. I wish I can make it in person. Unfortunately, due to I disciplined with some duties, so I take the opportunity to join with you online. So morning and happy Wednesday. This is Lujain Al-Sahman, Oral Medicine and Diagnostic Science PhD students. Today, I'm going to present one of the cases that I reported on my clinical practice on some type of technique. It is a unique technique that I use to diagnose and see the valuability of that technique. So before I start with my presentation, I would like to walk you through my presentation agenda. So firstly, we're going to discuss the biopsies, the need of the biopsy, and specifically the suture-threaded incisional biopsy of oral tissue, as I documented as a case report of a unique technique in oral cavity. We will discuss the oral mucosa pathology and various oral diseases that we can proceed with that technique, histological feature for this technique and incisional biopsy, and the investigation for that. So firstly, the word biopsy, as all we know, it is driven from a Greek word. Bio mean life and opsies mean vision, so we can know what's going on, what's hidden under that a piece of tissue. So biopsy of oral tissue is sometimes mandatory for pathogens that it is arise from unknown etiology, or if we have a sign of alert, like we have some area, anatomical area, that we concern about developing a pre-malignant or malignant diseases. So clinical examination, it is not enough. We have to go for a biopsy. We need second eye from pathologist so we can know what's going on. Also, we can diagnose not only pre-malignant lesion, but mostly we also have a vision of vesiculobullous diseases, which is sometimes related to immune disease, as oral tissue or oral cavity. Sometimes it is the first sign or alarm if anything going on in the whole body. So yeah, we can diagnose chronic ulcerative and desquamative lesion. So briefly, we can define biopsy as a removal of the tissue from a living organism, so we can know the characteristic of the tissue that we have. So this is my patient. He's a 32-year-old male, came as outpatient in dental clinic. He was his chief complaint mainly of a painless white patch under the tongue. Now his friend was dentist, so he was aware about the anatomical area, the white patch and painless. We concern about it because also the anatomical, as I mentioned before, under the tongue or lateral border of the tongue, for us, it is a dangerous zone. Also patient smoker. So yeah, it is high risk for developing a pre-malignant condition. Now, medically, he's fit, no medical issue, no medical problem. Extraoral examination, he's doing fine. Intraoral examination, no tissue abnormality, except on the area of the chief complaint. Now, under the tongue, we observe a 2 centimeter over 2 centimeter non-scrubbable white patch in the ventral surface of the tongue, and we decide to, of course, go for biopsy. We cannot diagnose this patient with limitation of the tools that we have in the clinic or with only an inspection. So yeah, we need a second eye to know what's going on. So we perform incisional biopsy with the suture-threaded technique that we firstly use because, you know, at this area, we have a lingual artery, so we are scared from, you know, complications. So we try to do a different technique. Also, the tongue is a really movable, super movable when we take biopsy. So patient cannot control his tongue. So we need a really quick technique in doing biopsy. So here is a gross examination of the histopathology, which is reveal a tiny wedge of oral mucosa with a whitish surface and yellowish base measured approximately 4 to 3 millimeter. Microscopic examination, it show altered in the oral mucosa, or the piece of the mucosa that we sent showed the stretch of the stratified squamous epithelium and the supporting connective tissue. The epithelium show a variable thickness, mostly thin, with a prominent stratium, granulosum, and hyperkeratosis as well. In addition to that, the epithelium showed mild dysplasia, which is a first sign that alert us that there is something going on with that patient with a focal area of moderate dysplasia. Also, the histopathological report reveal basal cell hyperplasia, loss of polarity, increase in nuclear as well, and also the submucus was composed of fatty tissue as well, vascular and focal aggregate of lymphocytes. So final diagnosis, it was leukoplakia with mild dysplasia, and the patient was put on close follow-up protocol. Now, here is a final diagnosis, show enough or comprehensive. It's good. Give us a comprehensive review of the what's going on in that area, which is for us. The good news at this technique is valuable to use, and it can be give the whole layer that the pathologist need. So, talking the oral cavity is a proper accommodate driven tissue type derived from a various germ layers with a different physiological rules that are intimately related. So as a consequence, oral mucosa is prone to develop virus reactive and infectious inflammatory immunomediated angioplastic lesion. A clinical suspicious of malignancy exists is persisting lesion such as enlarged lump, a chronic non-healing ulcers, and also a lesion with everted border and indurated margin on palpation. So yeah, a biopsy can confirm or deny a clinical impression. It is possible to determine also the behavior and the characteristic of the disease process. Sometimes a definitive diagnosis if the specimen was enough. So detection of the abnormal mucosa change being through clinical examination. But as I said, it is not only tool. We have to do biopsy, and we have to have assess from the pathologist to know exactly the definitive diagnosis. So here's a picture of the white patch as a patient came. Then we use the suture threaded technique, post suturing, and the healing process. Now, an oral biopsy procedure here was carefully carried out in the most of the cases in dental clinic, of course, under local anesthesia. There is potential for a flow throughout the biopsy path, and these might influence a secure and successful patient management. Correct diagnosis and treatments of oral lesion is significantly a part of the patient comprehensive care. And the basis of the, of course, the quality practice. There is no need sometimes for biopsy if the oral abnormality is obvious or there is an expert assigned to the case. However, sometimes we have to do biopsy, as I mentioned before, in the area which is we concern about. For pathogens also, that's unknown etiology, the biopsy will be the effortless and quick way to arrive the final diagnosis. Although a wide variety of biopsy technique and tools, there's many, but in this case, we see the different, and this technique we can, of course, we need to do more time, and we have to do it in different lesions in different area. But for this case, it shows a superiority than the regular incisional biopsy, as because quick time, so less bleeding, of course, and we can, and also the area, it is not comfortable, to work under the tongue. It is a movable organ, as I mentioned previously. So Thank you for listening. I enjoyed giving this presentation, and here is my account for any future collaboration, research work collaboration. I'll be happy to collaborate with anyone. Thank you so much. And if you have any question, just go ahead.
Hello, can you hear me?
So now let us begin our session of learning and sharing after the coffee break. Our next session is by Dr. Mariam Adizada from Iran. I'm passing her stage to deliver the speech on the report of an uncommon case of huge neurofibroma in the buccal mucosa. Over to you.
Yeah, it was coming. Hello, I am Maria Mohammad Alizadeh. I am oral and maxillofacial pathology resident in Iran in Shahid University. Okay, my presentation is about uncommon case of huge neurofibroma in buccal mucosa. I prefer to start with some questions. What is neurofibroma? Friedrich von Reichenhausen initially coined the concept of neurofibroma in 1882, noting that both neural and fibrotic components were present with its tumors. Neurofibroma are benign tumors from peripheral nerve origin composed of Schwann cells admixed with preneural-like cells, transitional cells, and fibroblasts. Is neurofibroma serious? Neurofibroma are benign tumors, but rarely cause medical issues. People who have multiple neurofibroma or large neurofibroma sometimes feel self-conscious about their appearance. An interesting point is that it can be associated with neurofibromatosis type 1. Why is neurofibromatosis important? It can cause scoliosis. It can associate with decreased bone mineral density, which increase the risk of osteoporosis. Sometimes the tumor develop on optic nerve, which can affect the vision. The most important point is high risk of malignant tumor formation. Lesions are divided in 3 categories: non-neoplastic, such as traumatic neuroma, benign tumors, such as schwannoma, neurofibroma, and preneuroma, and last one is malignant tumors. Fibroma may appear as a solitary or multiple lesion. most common in skin and head and neck region, and rarely detected on oral cavity. They're most common in third decade of life. Controversies regarding the sex predilection. Intraocular fibroma may be sessile nodule or pedunculated, varying size from small to large, slow growing, often painless, but may be painful due to pressure effect. The most common involvement site is tongue and buccal mucosa. It can be maybe in any site like palate or void, and rarely present over the lips. On a rare occasion, the tumor can arise centrally within the bone. Interosseous lesion has been described in mandible. Okay, I choose one crop panoramic radiography. You can see the location of neurofibroma may occur in inferior alveolar canal, cancellous bone, underlying the periosteum periphery. Neurofibroma may have a well-defined corticated border, despite the smoothness of brain. Some lesions may have indistinct margins. Internal structure, they may appear unilateral or multilateral. Neurofibroma of inferior alveolar nerve shows fusiform enlargement. Now, I want to talk about my case report. It's about a 6-year-old male patient, which referred to Department of Oral and Maxillofacial Pathology of Shaikh PhD, with chief complaint of swelling in his buccal mucosa since 1 year ago. The patient did not complain of any difficulty in swallowing, chewing, and breathing. No history of pain, discharge, or bleeding was associated with the swelling. Patient had a maxillary complete denture and no adverse oral habits. On a physical examination, the patient appeared healthy. Family history did not show a similar complaint in immediate or distant relatives. Okay. Or in this patient, the lesions relieved the presence of bell circumscribed, pale pink, oval, single, not tender, slightly mock, measuring 3 times 2 centimeters, and the surface was lobulated and non-oscillated. You can see excisional biopsy. And histopathological sections show a polypoid mass composed of spindle to polygonal cells in myxoid to dense connective tissue or stroma, which covered with hyperplastic to thin parakeratinized stratified squamous epithelium. Few mast cells and scattered inflammatory cells were present. One slide missing. Okay. For precise diagnosis, IHC for S100 was performed, which was positive. Now discuss about this case. We saw swelling on his buccal mucosa, which accordance with the lecture, as this is an uncommon intraoral site for appearance neurofibroma. The tumor size range from 0.1 to 2 centimeters in maximum dimension, which in our case it's 3 times 2 times 1 centimeter. Intraoral lesion of neural tissue mainly originated from the branches of fifth, seventh, and rarely ninth cranial layers. In our case, it involved the maxillary branches of fifth nerve. In a minority of patients have reported dysphonia, or respiratory difficulty, which correlated with tumors affecting the base of the tongue. But in our case, because the location was impacted, that the patient did not complain of any difficulty in swallowing, chewing, or respiration. After recurrence of solitary neurofibroma is rare, but it has been reported that there is a higher rate of recurrence in oral head and neck region. Also, tumors which have been excised several times have a higher risk for malignancy. Treatment option for neurofibroma is a surgical removal. However, the tumor size and its vascularization can often affect the surgical procedure. The preoperative histological evidence can influence the surgical approach being conservative or aggressive. Our patient was treated by digital biopsy, which was occurrence with the treatment protocol for solitary neurofibroma. No sign of recurrence or neurofibromatosis type 1 were noted, where a follow-up period of 24 months. Okay. Fibro. In 2070, WHO classification defines it as a benign peripheral nerve sheath tumor composed of mixture of palisade cells, neuroperitocytes, and fibroblasts and axons. Despite the early consideration of mature stromal cells as a pathologic origin, studies published recently following indicate the possibility that neurofibromas may originate from earlier stage of stromal cells. Okay, you can see the developmental stage of stromal cell lineage. You can see neurocells cells differentiate into boundary capsules and stromal cells precursors further develop into immature stromal cells. Then differentiate to myelin and non-myelin cells according to the associated axis. Then these mature types can be of mutation or injury into the repair stromal cells. Fibroma may assume one of the three growth patterns: localized, diffuse, and plexiform. Diffuse and plexiform have a close association with neurofibromas type 1. Localized sporadic neurofibroma and their inherited counterpart affect gender equally. Most develop in persons between age 20 and 30 years. Some of the says localized neurofibromas usually appear first during puberty and their number increases with the age. They grow slowly and with nodules that produce few symptoms. Plexiform neurofibroma that affect 25 to 50% of neurofibroma type 1 patients. The compression of plexiform neurofibroma could lead to severe clinical complications, including pain, tumor dysfunction, neurological impairments, and multiple oral organ damage. More importantly, plexiform have a malignant transformation potential, becoming malignant peripheral nerve sheath tumor. Multiple neurofibroma, you can see this in neurofibroma with type 1 syndrome and type 3 multiple endocrine neoplasia syndrome. Approximately 4 to 7% of patients with neurofibromatosis display oral manifestation. 20 to 60% of oral neurofibromas are associated with neurofibromatosis. Now it's time for neurofibromatosis. It's a hereditary neurocutaneous disease with significant effects of nervous system, eyes, skin, and bones. The clinical manifestation of neurofibromatosis type 1 include neurofibromas, scaphoid spots, freckles on skin, skeletal dysplasia, village nodule, and optic gliomas. The most common site is tongue and really on gingival, jawbone, and below of the mouth. Okay, you can see this is the picture of navel. You can see multiple neurofibroma. Here you can see one neurofibril like baggy shape. This is neurofibroma on tongue that makes unilaterally macroglossy. This is a consolidate spot and leash nodule. Okay. You can see in neurofibromatosis type 1, you can see the enlargement of coronary notch in the horizontal and vertical dimension. Here's the development of obtuse angle between the body and ramus, lensing and deformity of the condylar head, erosive change to the outer contour of the mandible, and interference with normal eruption of the molars also may occur. Okay. You can see their normal side and the side. Lateral bowing and thinning of the mandible ramus that's replaced with fat tissue. Okay. Another thing that is interesting is dysplasia of the sphenoid wings, the red one that show this graphic. Do you know what's the name of this? Okay, we said it empty orbit. Okay, neurofibroma is a non-encapsulated, discrete or diffuse proliferation of elongated and short spindle cells in delicately collagenous stroma with rarely myxoid or mucinous background. You can see the delicately collagenous stroma and spindle cells in it. Here you can see comma-shaped nuclei and many mast cells. It is interesting. In neurons say mast cells tend to be numerous and can be helpful diagnostic feature. Do you agree with this?
Not for diagnostic purpose, but yeah, they can be manipulated.
You can see diffuse neurofibroma exhibiting myosin corpuscles here. These pictures are from wound oral mandible. You can see that lesion is not encapsulated, and it is unencapsulated. You can see the rabies nuclei here. A variant of neurofibroma is dendritic cell neurofibroma, which is encapsulated. These cells have two types of cells. Type 1 is spindle cells and type 2 that large cells. You can see both populations are positive for S100 and large cells are positive for CD57. In conclusion, the importance of neurofibroma is the patient must be examined for neurofibromatosis because it has the potential for malignancy. Thank you. Do you have any questions?
Excellent presentation, Maria. Have you published this case in any journal?
No.
No, you have this case is from your personal collection, or you have published this case in any international journals?
This is my own case report, and this article published last year.
Because neurofibromas are very, very rare in Crawford. I have not come across any neurofibroma during my 40 years of career as a
Really?
Yes.
neurofibroma.
Iranians have more nervous.
Yes. This is in the order.
But you know, I mean, no, you are practicing where, madam? Okay, that means it may be more common in Gulf regions. But that's true, that would be true. Maybe it is, it has got some racial background or something like that. Because some races have more tumors of one particular kind. Anyway, it was excellent presentation.
Thanks.
And congratulations for that.
Thanks.
Have another question.
Yeah.
Have a question. Thank you for the nice presentation. I just want to ask for this particular patient, does the patient have any neuropathosis elsewhere or just the neurofibroma in the mouth?
Just neurofibroma. That makes this interesting.
So, yeah, it's just in the mouth, and what is unusual about this case? Just the size or?
The size and the location. And it's having any associated with neurofibromatosis. We have many neurofibroma in Iran just in 2 years ago. All of them that I see that was associated with neurofibromatosis, or they have a consolidate or at least one neurofibroma on their skin. But this patient having no evidence of neurofibromatosis. And you know, in Neville says the common site of the location is Khan, Balkan mucosa. But I searched for Balkan mucosa neurofibroma. I didn't find any article for that. So the location and the size was very large for neurofibroma.
Thank you, Dr. Mariam, for the excellent presentation. A small token of memento.
Thank you.
Our next speaker is Dr. Sudeep Khera from India. I'm passing him the stage to deliver the speech on assessment of diagnostic accuracy of urine and bladder wash cytology in urine bladder malignancy. Over to you, doctor.
Thank you. Thank you so much. I'm Dr. Sudeep. A very good morning to all of you. I've been working as an associate professor in Department of Pathology and Lab Medicine in All India Institute of Medical Sciences, Jodhpur. So my talk is on assessment of diagnostic accuracy of urine and bladder wash cytology in urinary bladder malignancies. So the cancer of the urinary bladder are the 10th most common cancer occurring worldwide, with almost 550,000 new cases detected in 2018 across the world. As per the IARC data 2018 fact sheet, almost 19,000 cases of bladder cancer were diagnosed in India in 2018, and which led to death of more than 10,000 individuals. Men are affected more commonly than the females, and with the median age of malignancy is about 60 years, and a strong association has been observed with cigarette smoking. So as my talk is actually based upon the cytomorphology of the cancer cells, so first we just need to know in urine with histopathological correlation was described in 1940s by Dr. George Papanicolaou and Dr. Marshall in their original works. They proposed a classification system which was based upon the cytomorphological features. And what are the features we are going to assess is the anisonucleosis, the hyperchromasia, the content of the chromatin content, and the enlargement, as well as cytoplasmic changes like basophilia and the vacuolization. So these are some of the changes which need to be observed while we are assessing the cytomorphology of these tumor cells. So we just need to have a system which actually brings the uniformity in reporting of the urinary cytology. So the Paris Working Group was organized in 2013 at International Congress of Cytology, which was comprising of cytopathologists, surgical pathologists, and urologists. Then this group published a systematic review in 2016 to standardize the reporting of urine cytology. So risk factors for urothelial carcinoma is exposure to the aromatic amines, aromatic hydrocarbons, and it is more commonly seen in industrial production of dyes, paints, metal, rubber, or petroleum products. Those who are working in these industries, they are more vulnerable to the development of these malignancies. Other risk factors are smoking, which has also been strongly associated with the development of bladder cancer, and of course the gender and the age of the patient. So the next slide is on pathogenesis of urothelial carcinomas. So most of these urothelial carcinomas are basically developing from papillary pathways, 80% of these cancers, and the 20% of the cases they develop through the non-papillary pathway. So this is the most common pathway which has been implicated in the pathogenesis of this tumor. So first there is hyperplasia, followed by papillary changes, which occurs in the urothelial lining, and it is associated with FGFR3 mutation, fibroblastic growth factor receptor 3 mutation. So these cancers, which are usually papillary in nature, they are low grade and multifocal, and they have higher chances of recurrence. Sometimes they do develop into a higher grade malignancies, and they can invade into the muscle layer, where they are called as myoinvasive bladder cancers. And the another pathway which has been described is non-papillary pathway, where the development of severe dysplasia is there. So followed by severe dysplasia, and then there is a breach in the basement membrane. So when there is a breach in the basement membrane, these cells are going to be invading into the underlying stroma, and eventually it invades into the underlying muscle also. So these are high grade malignancies, and they are associated with P53 genetic mutation, which is also known as guardian of genome. So this is basically tumor suppressor gene, and may be associated with retinoblastoma gene deletions. This is the WHO classification of tumors of the urothelial tract. So I will not get into the details. Broadly, they have been classified into urothelial malignancies, infiltrative urothelial carcinomas, non-invasive urothelial neoplasms, the squamous cell carcinomas, glandular neoplasms, which are comprising of glands and which can be of various type, enteric type lining epithelium, mucinous and mixed type of epithelial lining, urachal carcinomas, and neuroendocrine tumors, which are again very aggressive tumors of the bladder, melanocytic tumors, which are arising from those melanocytes, and the last category is mesenchymal tumors. So this is broadly about the classification system. Now we come to the Paris system. So the Paris system is basically has been introduced for the standardization of reporting in the urine cytology. But before that, the standardization of reporting in cytopathology was initiated in 1988 with the Bethesda system for reporting cervical cytology. So it has gained a worldwide acceptance, and since then it has been the model for development of standardized reporting system in cytopathology. The other systems which are being followed is for pancreaticobiliary system. This is again Papanicolaou system which is being followed, and the thyroid system, again where we are using the Bethesda system for reporting thyroid cytopathology. So the International Academy of Cytology Congress meeting, which was held in Paris in 2013, and where this idea was actually conceived for reporting urine cytopathology by Dr. Rosenthal and Dr. Wojcik, built a successful consensus with by taking inputs from international cytopathology and urology communities. They included 49 members from the 10 different nations, which was again a group which was comprising of cytopathologists, uropathologists, and surgeons, urosurgeons. So the Paris system, again, it is based upon the assessment of these features, which I have already discussed earlier. So after introducing these systems, many centers have actually reviewed their records and conducted retrospective studies to reclassify the urine cytology system according to the Paris criteria or Paris system. So these are the categories which has been described. The first category is unsatisfactory or non-diagnostic, where we cannot actually where a lot of inflammation or hemorrhage is there, which is obscuring the morphology of the cytological details, then we could actually categorize it as unsatisfactory or non-diagnostic category. The second category is negative for high-grade urothelial carcinomas, where we could we could say with conviction that it is negative for high-grade urothelial carcinomas, but still we cannot rule out the possibility of low-grade malignancies or low-grade urothelial neoplasms. The third category is atypical category, which is again an ambiguous category, where we are not sure, and it is a kind of equivocal category where we are not sure whether it is really actually malignant or not malignant. That needs to be followed up. Then the third category is suspicious for high-grade carcinomas, where suspicious when the number of the cells are quantitatively, the number of the cells are less than 5 to 10 in number. Then we call it as a suspicious, though they have all the features which are meeting the criteria of labeling it as a high-grade urothelial carcinomas, but still we cannot call them straightforward malignant. Then the sixth category is low-grade urothelial neoplasms, where we need to have a papillae formation with a proper fibrovascular core, which could be identified. So other lesions, other tumors which are noted in the bladders are primary and metastatic lesions. If we have any doubt that this could not be the conventional urothelial carcinomas, then we can put them under the last category, which is described as primary and metastatic lesion. So this is the diagnostic algorithm which is being followed. So we need to look at the cytological atypia first. Cytological atypia, followed by, if there is cytological atypia, then we have to look at the degree of atypia, whether it is mild atypia or severe atypia. Mild atypia, we need to calculate the nucleocytoplasmic ratio. So in our study, we have actually used an analysis software, which is ImageJ software, to calculate this nucleocytoplasmic ratio. And it has to be associated with other features. One of the other features like hyperchromasia, the irregular distribution of the chromatin. If it is severe atypia, the nucleocytoplasmic ratio is more than 0.7 associated with hyperchromasia and Coles chromatin and irregular distribution of the chromatin. Then we can call it as severe. So the main emphasis is on nucleocytoplasmic ratio, which actually brings the objectivity in the classification system. So if it is milder degree of atypia, then we have to exclude the other causes for mild atypia. Like sometimes these cells may show atypical changes if the bladder, if the patient is having a severe cystitis. So these changes, these patients may, cytological cells may demonstrate the presence of atypia. So we need to look at, we have to exclude those causes also, instrumentation or any kind of inflammation which is associated with this degree of atypia. So if we have excluded all the other possibilities, that it is not because of inflammation or not because of any instrumentation, then we can put it under the category of atypia of undetermined significance. So now we have to look at the number of atypical cells or the quantity of the atypical cells. If the number of atypical cells are rare, if it is less than 5 to 10 cells, then we could categorize it under the category suspicious for high-grade urothelial carcinomas. If there are many cells which have been identified, which are more than 10 in number, clusters of cells, singly lying cells, or isolated scattered population of cells, then we can call it as positive for high-grade urothelial cancers. So with brief introduction about this, the Paris system, and briefly about the urinary bladder malignancies, I come to my study. The aims and objectives of my study, what we have conducted in AIIMS Jodhpur, to assess the diagnostic accuracy of urine cytology and bladder wash cytology using the Paris system for reporting urine cytology by correlating with the histopathological diagnosis. So histopathology is our gold standard. So we are comparing our results with the final histopathology once the tumor has been resected and submitted for histopathological evaluation. Then what we have evaluated in this study is sensitivity, specificity, positive predictive value, and negative predictive value of urine and bladder wash cytology by cytohistological correlation. And we have also compared the wash, where at the time of cystoscopy, the surgeon or the urosurgeons, what they are going to do is they are going to instill the bladder with the saline, and they are going to take the bladder wash, and this bladder wash will be subjected to cytological evaluation, and we are going to assess the cytomorphology of those cells. So how it could be helpful in detecting the lesions. So this was an observational study, prospective study, which was conducted at Department of Pathology in AIIMS, Jodhpur. The study was conducted from January 2020 to November 2021. A total of 59 patients were included in this study, which were meeting the inclusion and exclusion criteria, of which 48 had histopathologically confirmed tumors. So out of which only 48 patients had histopathologically confirmed tumor in the urinary bladder. The cytology samples were collected, the urine cytology samples were collected, and they were centrifuged in 5 ml test tubes in Eppendorf at 2000 rotations per rotation per minute for 10 minutes to obtain the cellular sediment. The supernatant was discarded. Then this cellular supernatant was smeared on the glass slide to prepare at least 2 smears. So one of the smear was actually stained with air dried, and the another one was fixed in 95% ethanol, which was stained with Papanicolaou stain. And finally, the results of these cytology was compared with the histopathology, which we have received later on in the department. And approval for this particular study was taken from the Institutional Review Board. So after examining those cytomorphology of the cells, we have captured the cells of interest under the oil immersion using UC501S software, which is basically this particular software was used. Then the images were analyzed using ImageJ software. What I have told earlier, that we have calculated the nucleocytoplasmic ratio with the help of this particular software. The data which was generated by analysis of the images was interpreted to help classify the cytology smears into the categories by using the Paris system. And it was, so those cases where on cytomorphology, the tumor was detected, then they undergo, those patients underwent cystectomy, and the specimen was submitted, and in few of the patients, the radical cystectomy was done, and majority of the patients underwent transurethral resection of the bladder tumor, which was received from the Department of Urology, and they were actually processed, and the routine histopathology processing was done for these cases, and H&E stain sections of the cases of urothelial carcinomas was diagnosed with relevant immunohistochemistry markers wherever it was found to be necessary. So microscopic features of the bladder tumor was noted and classified as per the WHO classification of the tumors of the urothelial tract. So moving on to the observation and results. So the median age of the patient with the tumor was 64 years with a range of 31 to 87 years. Majority of the patients included in the study were males. Out of 48 patients where we have actually histopathologically confirmed tumors, 43 were found to be 43 patients were males and 5 were females, with a male-female ratio was calculated as 8.6:1. This was the age distribution of the cases. So here in this table, we can actually see the majority of the patients were reported in 5th to 6th decade of life. So patients with tumor, 12 cases which were reported between the ages of 50 to 60 years of age group, and 61 to 70, 14 patients were reported with malignancy. So now, as we know about it, that there is a strong association of malignancy with smoking, and presentation of these patients is with painless hematuria. So 30 patients which were included in the study were smokers, and 10 of these patients had high-grade urothelial carcinoma, 1 other patient had small cell carcinoma, and the another 2 patients didn't have any tumor on histopathology. So here we can actually see majority of the patients who were smokers, they developed high-grade urothelial malignancies, and 23 patients which were included in the study presented with hematuria, of which 20 patients had tumor confirmed on histopathology, and the 3 patients had features of cystitis, of which 1 was culture confirmed case of Mycobacterium tuberculosis infection, which was confirmed on histopathological examination. So of the 20 patients with the tumor, 1 patient had squamous cell carcinoma, 1 had small cell carcinoma of urinary bladder, and the rest were cases of high-grade urothelial carcinomas. So these 2 cases, squamous cell carcinomas and small cell carcinomas, they were actually placed under the category of others and metastatic others lesion. So how many urine samples we have received? It was about 144 urine specimen, and 15 barbotage specimens were received from the 59 patients included in the study. Urine samples for malignant cytology were received from 54 of these patients. Of these patients who submitted urine samples, the 3 consecutive day samples. So this is actually a dictum which is being followed whenever the urine cytology is being done. So it is advisable that at least 3 samples on 3 consecutive days should be submitted for cytological evaluation, which enhances the sensitivity of the urine cytological examination, and picking the detection rate of malignancy is high while we are submitting 3 samples on 3 consecutive days. So we received in 40 cases 3 consecutive samples, and 10 cases only 2 samples were available, and 4 patients submitted only 1 sample for malignant cytology. So both urine and barbotase samples were received in 10 cases. So there were 10 on only barbotase samples were received in 5 cases. So while we look at this particular table, which shows the distribution, so here 144 urine samples were received, and we can see that majority of them were reported as high-grade urothelial carcinomas, 50 cases, and 44 cases were reported as 44 samples were reported as unsatisfactory. And under the barbotase samples, 15 samples were received, and in this particular category also 6 samples were reported as high-grade urothelial carcinomas, and 4 were reported as unsatisfactory. So this is the histopathology specimen distribution. What are the specimens which we have received? So transurethral resection of the bladder tumor, which was received in 29 cases. Transurethral resection biopsy, which was received in 21 cases. And there was one case which was where the transurethral resection of prostate and biopsy both were done. And radical cystectomy was performed in 6 cases. So comparison of cytology with histopathology. So the cases which were reported as high grade, here we can see, pointer is there. So high grade. So 33 cases which were reported as high grade on histopathological examinations, the 25 cases which were found to be high grade on cytological examination too. So that actually shows that there was a good correlation or good concordance rate between the histopathology as well as cytopathological evaluation. So this was actually including both the samples, urine samples as well as barbotase samples. The other slide is actually showing only the urine cytology specimens. Here also we can see the total 28 cases which were reported as high grade on histopathology, and of which 22 cases were also reported as high grade urothelial carcinomas on cytomorphology. So it is also showing good correlation. And barbotase cytology, if you examine, so here the 10 cases were reported as high grade, and out of which 6 cases were picked up as high-grade urothelial carcinomas on barbotase specimens. So then we put all these values in the SPSS software, which is being used for calculating the statistical analysis. So the sensitivity, which was picked up as 84%, and specificity was 95%, and positive and negative predictive value was recorded as 96 and 80%, and accuracy was 89%. So we have actually split this data into two. When we took atypical urothelial carcinomas as negative, and in the other instance, we took atypical urothelial carcinoma category as positive one. So the sensitivity and the specificity was actually varying. So the bladder barbotase specimens, again, we have calculated the diagnostic accuracy. So the sensitivity here we can see it was 70%, and it was reported as 80% when atypical urothelial cancer cells was considered as positive. And the specificity and positive predictive value was found to be 100% in both the instances. And we also calculated the diagnostic accuracy of the Paris system for low-grade malignancies as well as other malignancies. So here we can actually see the sensitivity is quite low, only 65% in cases of low-grade malignancies. But in earlier slides, we have seen for picking up the high-grade malignancies, the sensitivity is high for those urine cytological samples as well as barbotase sample. So this is a major limitation of the Paris system, that it may miss low-grade malignancies. Then we also calculated the risk of malignant transformation based upon the categories. So as we can see, the risk of malignancy is increasing as we are progressing from unsatisfactory category to the others category. So here we can see if we have reported high-grade urothelial carcinomas on TPS category or the Paris system category, the chances of malignant transformation, or if we receive the histopathology, it is 100% that the sample is going to be, the specimen is going to be positive for the malignancy. So And similarly, we have also calculated the risk of neoplasm for the low-grade malignancies too. So these are the specimens which we have actually received. This is a radical cystectomy specimen which was received in the department, which is actually showing multifocal papillary urothelial cancer. It was low-grade tumor. Here, this is the benign urothelial cell, which was reported in the urine as negative for high-grade urothelial cancer. On histopathology, this patient had features of inflammation without any evidence of malignancy. And here we can actually see the cluster of the cells which are showing a cluster of atypical urothelial cells, the high NC ratio, which was calculated and it was found to be more than 0.5. And these cells were also displaying features of hyperchromasia and few cells with nuclear membrane irregularity. So it was reported as atypical urothelial cells. And on histopathological examination evaluation, it turned out to be low-grade urothelial carcinoma in this particular case. This image is actually showing the cell which is having a very high NC ratio. Here we can actually see very high NC ratio. It is about more than 0.7 and it is having irregular distribution of probity and nuclear membrane irregularity. So it was reported as high-grade urothelial carcinoma. And even on histopathological evaluation, it turned out to be high-grade urothelial cancers. And this case was reported as high-grade urothelial carcinoma with squamous differentiation. So whenever we are looking at this type of cells which are having tadpole-like effect or stretching of the cytoplasm, so they may represent that these tumors may have undergone some kind of squamoid differentiation. These are the histopathological images, the low-grade urothelial cancer. So here we can actually see the fibrovascular core. So these are basically the fibrovascular core, which are basically noted in low-grade urothelial malignancies. And here we can see the cells, the way they have arranged themselves. It is not very much in the non-regimented fashion. They are not. They have not lost their polarity. They are still maintaining this thing, and there are too many fibrovascular cores. So it was reported as low-grade urothelial carcinomas on TURBT specimen. Then the next image, we can see high-grade urothelial carcinoma. If you compare it with the previous image, you can see there is a wider variation in the size of the nucleus. So there is a lot of variation in the size of the nucleus. So it is showing a higher degree of pleomorphism. So finally, it was reported as high-grade urothelial carcinomas. And in the next image, we can see this is squamoid differentiation, which is occurring on the right-hand side of the image. We can see there is a dense eosinophilic cytoplasm and the cells are having polygonal appearance. So it is representing the squamoid differentiation. These tumors, urothelial or bladder malignancies, they are prone to develop divergent differentiation. So in this slide, we can see, and on the other side, we can see there is a spindle-shaped cells which are proliferating in the same tumor. So it is representing the sarcomatoid transformation. So both the transformations or differentiation were recorded in the same case, squamoid as well as sarcomatoid differentiation. And whenever there is sarcomatoid differentiation or associated with the bladder malignancies, it indicates poor prognosis in such cases. So it was a case of pure squamous cell carcinomas where we can actually see a large number of squamous pulses which have been formed in this particular case. So it was reported as pure squamous cell carcinomas. The another case is showing urachal carcinomas where we could see the presence of intestinal type of glands. These are intestinal type of glands which are lined by tall columnar cells and exhibiting all features of cytological atypia and associated with this wispy mucinous substance in the background. So this is large pools of extracellular mucin which was noted over here. So it was reported as urachal adenocarcinoma. Then the next slide, we can see this is a case of small cell carcinoma of the bladder. So here we can see the cells appear very monomorphic in appearance and they have high NC ratio and exhibiting hyperchromasia features, and they are arranged in the sheets. So it is a small cell carcinoma of the bladder, microscopy of small cell carcinoma of bladder, which is again associated with unfavorable prognosis and very aggressive course too. So the overall sensitivity of cytological examination by using both the samples, including urine and Barbote's samples, utilizing the Paris system for reporting for high-grade urothelial carcinoma was 84%. Then the specificity was 95%, and the positive predictive value, which was calculated as 96, and the negative predictive value was 80.7%. So in other studies, when we have compared our results, the sensitivity using the Paris system has been reported from 10% to 84%. With the highest sensitivity reported by Malirox et al. Specificity as high as 100% with sample size of 100 has been reported by Bakar et al. Other studies reported a specificity of at least 73%. The overall diagnostic accuracy in these study has been in between 69 to 81%. In our study, the diagnostic accuracy for high-grade urothelial carcinoma was found to be 89% with high specificity and positive predictive value of 95 and 96% respectively. So these are the diagnostic parameters for the Paris system for reporting urine cytology. So while we are including all the tumors, including the low-grade malignancy, the sensitivity is low, but whereas for high-grade urothelial carcinomas, we can see the sensitivity as well as accuracy. Both the parameters are quite high, 89% and 84%. So this table actually shows us that the sensitivity of picking up low-grade tumor is low on the Paris system. So what were the strengths of this particular study? It was a prospective study which has compared the cytological and histopathological features. Earlier, the many studies have been conducted where they have reviewed the record from the past. So it was kind of retrospective study, but it was a prospective study where we have compared cytology followed by histopathological features. So this removed any selection and verification bias that can be observed in retrospective studies. We have analyzed both the samples, bladder Barbeau samples and urine samples separately and compared the diagnostic parameters too. So diagnostic parameters were calculated for high-grade urothelial carcinomas as well as for other different neoplastic pathologies of the urinary bladder. So we could compare the diagnostic accuracy of the Paris system for high-grade as well as for the other bladder neoplasms. And the other thing is the morphometrical analysis was actually performed, which was using this ImageJ analysis software. So which brings the objectivity in the study and it reduces the inter-observer variability. So the limitation of the study was the sample size was not, sample size was only about 59 cases and with 48 cases have been confirmed on histopathology as a malignancy because of the COVID pandemic that was going on. So the footfall of the patient was also reduced and not many patients were coming to the hospital during that time. Only 15 bladder Barbeau samples could be included in the study. So which has limited the comparison of urine with bladder Barbeau. And we excluded the cases of recurrent bladder tumors. So we couldn't analyze the role of the Paris system for reporting urine cytology in surveillance of recurrent cases following therapy. The conclusion is this study has demonstrated the Paris system for reporting urine cytology is a helpful tool to make accurate diagnosis of high-grade urothelial carcinomas even before any invasive procedure. The system has good sensitivity as well as specificity for high-grade tumors. Both urine samples as well as Barbeau samples are helpful to diagnose high-grade urothelial malignancies. The sensitivity of the system for detecting low-grade malignancy is low, signifying the importance of further evaluation of the patients with negative cytology. The risk of malignancy increased progressively from negative for high-grade urothelial carcinoma category to high-grade urothelial cancers category. Therefore, application of the Paris system is a sensitive screening tool for urinary bladder malignancies. So these are my references. Acknowledgements. And this is the institution where I've been working. Thank you so much. Any questions? Yes.
Thank you, Dr. Sodhi, for this nice presentation. I have really two questions. Number one, about what is the preferred time for urine collection, urine cytology?
Yes, sir.
Really, almost we getting samples at night from person
Yes, sir.
that usually seen in the clinics.
Okay.
And the second question, what is the Paris system is useful in assessing patient of non cases of urinary bladder after therapy?
No, sir. Not now, but we can apply this Paris system for assessing those patients also who can actually present with recurrences later on. So this system can be utilized there also. If those patients who are presenting again with some kind of recurrences and the urinary bladder malignancies, but this system is not meant for assessing the other malignancies. There are other systems which are being used for cytomorphological analysis of thyroid malignancies as well as pancreaticobiliary malignancies. So, and Bethesda system has been there, which has also been used worldwide to assess the cervicovaginal cytology as well as thyroid cytopathology.
What about the preferred time for urine collection samples?
Preferred time, sir. Basically, we are getting samples during the OPD hours only. So as soon as we receive the samples from the clinical side, so those samples will be centrifuged immediately and they will be prepared. The smears will be prepared as per the protocol.
Already hear that the early morning sample is the most preferred one. That's true.
Pardon, sir, I didn't.
Early morning sample or first
Morning sample, first morning sample, yes, sir. If it is preferable, but if it is not possible or the patient has not collected the first morning sample, the other samples which may have been collected at other time of day, they may also work for us. Yes, ma'am. There are high chances they can transform into malignancies. And because if they accumulate other mutations, like as I have told, some low-grade malignancies have been reported in the bladder. If they accumulate other mutations like P53 mutations or retinoblastoma gene mutations, so they can actually transform into a high-grade malignancies too. Not really, ma'am, any relation.
Not the benign hyperplastic, but many means locally malignant prostate cancer.
Yes, ma'am. They can actually metastasize into the urinary bladder, those prostatic malignancies, but they are not the true bladder malignancies that could be reported as a secondary to the bladder. Secondary to the bladder.
Carcinoma or grade it's low or sometimes it's unclear, low or potential malignancy. Using B53 and CK20 or what are the sensitivity of them? How percentage of them are not nuclear staining of B53, which are confirmed it is low, not potential.
Ma'am, P53, there is an IHC markers are also, IHC facility is also available for P53. This genetic mutation can be demonstrated with the help of IHC, which can be basically a surrogate marker for those genetic mutations. If P53,
Say it is no malignancy mutation. Of them, but high grade is very easy. But the medium and potential malignancy, it is here the difficulty, and we can use sometimes we use B53, but it is even as CK20, it is not so much.
Yes, ma'am.
The confusion as we say, most of them are low, but it is.
Any specific feature to distinguish between low-grade malignancies as well as high-grade malignancy? But low on cytomorphology or histopathology. So there are these papillae formation is there, and we have to look at the mitotic count. If the mitotic count, yes, this is little far from. KI67 is.
Because you can only in the umbrella cells.
Umbrella cell layers.
And when it is that both of them the same stage, most of them.
Yes, ma'am.
The time, potential malignancy and or low grade, same staining. How can I, if it is sometimes it is then.
Sometimes it becomes really difficult to differentiate. And there are certain bladder malignancies where we could actually see both type of areas, low grade as well as high grade areas also. So they can be put under the intermediate grade categories also. Maybe. Yes, the KI67 may help us, ma'am, but it becomes key 6.
Just beside the
I think
the only thing is, ma'am, we have to assess the cytomorphological features. If they are favoring the low grade category, because there is one more category which has been described, that is PUNLMP, papillary urothelial neoplasm of low malignant potential. So we just have to look at the cyto.
recommendation to.
And we can advise. And it is advisable to call the patient for follow. It is better to call the patient for follow after performing the key 67 assay and all these things. But we may not be so conclusive that it is a low grade sometimes, but not in all the cases. It's really important.
My patient, so, like, they presented that mostly result oriented and they're running publications in 2022 specifically. They say that CD44 confers indefinitely.
Yes.
It has more line weight potential and hydrates are more likely to than CD44. And like man already mentioned, CD20 retainment of umbrella term that is quite helpful in some scenarios, not all. But as for the patient's perspective, they always say that even if you find a 5% component of hydrate, better go for more aggressive services. That's to be on the safe side.
Yes.
That's what.
Thank you for the excellent presentation. I just want to ask you a question, maybe about the fish technique. Have you ever considered doing Eurovision with the alongside with the cytology, or because the sensitivity, especially for the low grade disease of that?
Yes, sir.
Have you considered this, or are you looking at?
Not in this study, sir, we have considered, but we are planning to have one more study where we could actually go ahead with this fish cytology or Eurovision probes, which could be really helpful in even in detection of the recurrence of the tumors, as well as in the low grade malignancies, which can also be picked up with the help of those genes.
Thank you.
Thank you, sir.
Thank you, Dr. Sudeep Khera, for the excellent presentation. It was extensive and elaborate, and you've explained everything very well.
Thank you.
Thank you. There is a token of momentum. Now I'm passing on the stage to my colleague, Dr. Mariam, who will be chairing today's session along with me. Hello, Dr.
Our next speaker is Dr. Digital Pathology from India. I'm passing her the stage to deliver his speech on pathology findings on recall, contract photoadenectomy, and single center experience.
Oh, I think this one. Good morning. There's a slight change. I have two topics for today. So I'm in place of another doctor who needs an emergency. So I'm taking the last case as my first case for today. Cervicofacial actinomycotic osteomyelitis, a single center study. I'm Dr. Vinila from Apollo Institute of Medical Sciences and Research. It's a medical college in Hyderabad. I'm an associate professor in that institute. We are different wing compared to the Apollo hospitals, but we are part of the family of Apollo Group. Okay, coming to the topic as such, actinomycosis, as we all know, it's a commensal of our oropharyngeal system, GI tract, urogenital tract. But this topic has created an interest in me that this has created as an osteomyelitic lesion, which was very difficult to diagnose clinically and radiologically. So what goes under the history and before we diagnose it made me to take this topic.
as forward. So as a great masquerader of head and neck lesions, usually on the head and neck, we usually look for all the odontogenic cyst or malignancies. Very rarely we come across an infectious cause leading to a severe lesion of the osteomyelitis. So actinomycosis refers to a ray-like appearance of the organism because of those granules which are seen in the microscopy. It is an anaerobic bacteria. It is aerophilic, and it is non-acid fast filamentous gram-positive bacteria. It causes a chronic granulomatous inflammation, and it usually involves the respiratory tract, GI tract after breach in its mucosal epithelium layer. Anywhere there's a breach, this lesion will kind to infiltrate and cause a disease underneath. So actinomycosis usually affects the bone, but in the cervicofacial region, it is very rare. And in that rarity, it is the most rare is the maxilla part. If you can take it, it usually involves the mandible. So the involvement of maxilla is around 5% or somewhere around 0.5% to 9%. So the aim of my study is it's a retrospective study. Why retrospective? We never thought this lesion could lead to an osteomyelitis. We were ourselves surprised that it could happen. So it was a retrospective observational study for a period of 1 year. So this is my first case. This was a very young boy, a 17 years old boy who had come to us with a radicular cyst. And it was recurring all the time. This is his second recurrence after the lesion was removed. So the orthodontist had a clue saying us that there is some kind of underlining, some sinus was there once the radicular cyst has been removed. This gave us a clue saying that there is something more than what is required. So we asked the orthodontist to take a biopsy bit for us and send it back. Take a deeper bits is what we asked him. So to our surprise, when he's taken the deeper bits, we could see a lot of colonies of these actinomycosis sitting there in the trabecular spaces, absolutely silently. Usually when you have infectious lesion sitting there, tuberculosis, or any kind of fungal inflammation, they're usually surrounded with a lot of giant cells and chronic inflammation. But somehow this actinomycosis was very silently sitting there, very, very few of lymphocytes. We were ourselves astonished that this could lead to such a lesion. Then we started digging the journals and the history. Then we saw that this could lead to that of an actinomycotic osteomyelitis in the orofacial bones. So in the cervical bones. And this lesion was not actually scalloping. It was just sitting there and creating a silent inflammatory lesion. So that was our first case of the year in that year. And then we followed it with the next case of after a month period, which was a 30 years old adult. This person had a clue that they could be a fungal. It was the COVID era, where the white fungus, the black fungus, all the funguses, different colors were erupting. And the clinician gave us a clue that this could be a fungal osteomyelitis. To us, also, there were some kind of clue thinking that they would be a fungal lesion, and they sent us multiple bony bits. And we had an extra help here. We took the X-ray pictures from our orthodontist, and they gave us pictures saying that there's some kind of a lesion in the maxilla, which was almost going into the frontal base of the orbit. And they said that because it is the COVID scenario going on, maybe it was an angioinvasive fungus which was going into the orbit. Then he's given us more clues saying that this lesion was actually infiltrating the palate also. Then we had a clinical picture of him that they had a lesion over here and here. So there were multiple lesions on the face, saying us it could still be a fungal lesion leading to all of this. But to our surprise, there was no fungus. There was big colony of actinomycosis, which was infiltrating into the base of the orbit, just infiltrating. And this lesion had a a surrounding inflammatory reaction. Maybe this clue is whenever it is surrounded by an inflammatory reaction around it, it is infiltrating to the bone into another invasion into the surrounding structures. The rest, the before slide or the before case, we never had any inflammation. It was just sitting there, irritating the bone and having a little bit of inflammation of lymphocytes and plasma cell. But this, when we saw from multiple areas, this lesion where had a lot of chronic inflammatory infiltration. Then we had a third case, supposedly the surprising part the next day. And he was a 25 years old young person. We considered it to be a pyogenic osteomyelitis, no history of any COVID scenario. It was just multiple discharging sinuses, absolute bing on saying about the history. There were a lot of discharging sinuses. The moment we got this, we said, yes, it is actinomycosis before we could see it under the microscope. So as such, yes, this is a head and neck surgeon who had helped us with this, with the pictures. And what they did is, because they had already clue of actinomycosis, they took a mold. They took a mold of their mandible, just like how you do dentistry, where you take a mold of your teeth and create an artificial how your teeth are being aligned. They have taken a mold of the jaw of the patient and create an alignment of the jaw. And they have restructured an artificial, because they had to remove whole of the jaw, and their graft needs some kind of a bony support over there. So this was pictured because we already knew that it will come out positive. So we asked them to keep sending us pictures of these draining sinuses. Is given, and this was the space they were trying to refill for the person then when they graft. So they took the actual mold like this of the patient jawline, and they have created a plate. So this artificial grafting, then they've created a plate over it, and this was being kept in the place where of the debridement. So they did a surgical debridement at the time of removing the part itself, because they knew it would be actinomycotic osteomyelitis of the draining sinuses. And it was no surprise that it was an actinomycotic osteomyelitis. This also didn't have any much inflammation, only mild inflammation, though it was so much involving the jaw, but it was not infiltrating into any other bone except the mandible. So coming to our topic, cervicofacial actinomycotic osteomyelitis. Why did I present this? It's a very rare presentation involving the cervicofacial region, and it has different names: lumpy jaw, hard jaw, wooden tongue, and all. Whenever it involves the jaw and it is very loose, it's called as lump jaw. When it involves the hard bone penetrating into the bone tissue, it is called as hard jaw. When it involves the tongue, it creates a very hard tongue. It's called as wooden tongue. So different variants we have of actinomycotic lesions. The one of them, which is very, very common, is Israeli. Histopathologists have no role to play with the species. We only know it is the genus of it. Still, some surprising thing, actinomycosis as such is not virulent, because it requires some kind of a symbiotic association with a bacteria for it to penetrate into the tissue. As long as it is over the surface, it doesn't create any kind of a disease. That's why it is called as non-commensal in our mouth, oropharynx, your urogenital system, and all. So what does this lesion actually cause? The underlying pathology is any kind of disruption of the mucosal epithelial lining. And this disruption could be that of caries, or due to that some kind of a cyst rupture, due to that of some kind of a bacterial association, which can cause the mucosal eruption and thus causing the invasion of actinomycosis into the bone. So the prerequisites for this lesion is there should be a break in an integrity of the mucous membrane. There should be a trauma. There should be some kind of dental extractions which are not being completely treated, caries, and there should always be a symbiotic association with some kind of bacterial flora. And you should have also devitalized tissue present there. This devitalized tissue will create the bacteria to enter into deeper structures and thus causing the sinuses effect. So grossly, how do you identify this? Discharging sinuses causing a small sulfur-like granules being present. And this sulfur-like granules are nothing but the actinomycotic lesions as such. And what is the diagnostic challenge? Very, very difficult to know it in a gross picture or before getting the histopathology, because you should have a clue of this lesion when you have any kind of discharging sinuses is bingo. But when you don't have it, you should have a clue when it is not, when you have a tooth eruption, which has not been subsided automatically, or which has not been subsided with normal antibiotics or normal treatment, then you should always have a clue that there is some kind of lesion other than the fungal. There is an actinomycotic underlining it, which could be causing this lesion. So diagnosis, yes, it's always histopathology, which confirms the genus. But if you want to know the species of it, there is a latest study in the microbiology department, which leads to that of 16 years ribosomal RNA gene sequencing, which will help to identify the species also. And there's another methodology called as matrix assisted laser desorption. It's nothing but this causes the secretion. I mean, this causes the laser beams will cause the removal of the ions from the cells and cause the identification of these ions. And thus you can able to identify the actinomycosis in a very fast and accurate manner is what they say. The other method is polymerase chain reaction method, using specific primers to identify the actinomycotic lesion. What is the significance of this disease? Why it's so important from the other bacterial, other fungal is, yes, it could be cured. It could be done if you have been identified in the early stages. Yes, you need a vigorous surgical debridement and a very extended antibiotic treatment, not for 2 weeks, not for 3 weeks. It is 4 to 6 weeks continuously for 6 weeks, that most almost 1.5 months, and then keep reviewing the patient, and if required, this antibiotic treatment should continue for 12 months also, and keep checking him back that there is no any recurrence or any left out of the actinomycotic lesion, because even if you leave a little amount of it, we don't know how much, but if you have a part of it left behind, it will cause a recurrence. So early diagnosis, antibiotic extended treatment, and very, very extensive surgical debridement of that area, preferably the whole part of that bone. Conclusion, clinical radiological diagnosis is very, very difficult unless until you have a draining sinuses of this lesion. And always try to suspect in the area whenever you have a disease which is recurring and not being subsided by a antibiotic course. Then always have an actinomycotic back in your mind. Also think that progressive lesions of actinomycosis, especially of that of maxilla, be careful. It can go to that of orbit involvement and thus cause an unnecessary death or unnecessary loss of vision of the patient, which could be prevented in an early stage. Those are my references. Thank you so much. Any questions? Yeah, yes, ma'am.
So my question is visualizes and not accompanied by modified or
it does cause. It doesn't have to cause a necrotic bone tissue, no need. But if it is there, necrotic bone tissue, that means it is going to a progressive stage. Progressive.
Is it like
yes, we had innumerable, yes, ma'am. We had innumerable of cases where in tonsils and in adenoids, we had actinomycosis sitting very silently over there inside the lymphoid follicles, but it never did anything to that. I don't know the reason behind it, but there was.
If you find the dead wall or not, you have to get those guys.
Yes. Yes. If you find it in between the trabecular, that means it has penetrated into the trabecular spaces. But if it's lying on the surface of your GI tract, lying on the surface of the respiratory tract, anyway on the surface, it is not actinomycotic invasion. It has to penetrate into the tissue. Exception for them is tonsils and adenoids. Even if you see in the tonsils and adenoids within the tissue, still it is considered to be a normal commensal. Normal commensal, yes. Yes, ma'am. Yes, ma'am.
The patient have history of COVID.
No.
Are you sure?
Yes, ma'am.
So we have a similar like that in Iran, but we have history of COVID. And we have this theory make there is an associate between myelitis and COVID that this myelitis is a tissue to other organisms like them like mucormycosis or actinomycosis can invade into. In your sections, the actinomycosis was in the periphery. Yes.
Yes.
That's I think it's osteomyelitis at first, and then it's associated with actinomycosis.
Maybe, but
I think so.
maybe.
If the actinomycosis invaded to, it's when you can say it's actinomycosis that make osteomyelitis.
Yes.
It's arbitrary.
Yeah, I'll just add a point. Yeah, ma'am. We didn't have any history of COVID in the 6 to 8 weeks of these patients, but there would be they might be that the treatment would have been delayed because of the COVID scenario. They couldn't reach the hospital, or they didn't want to come to the hospital, maybe one. As you also say that, yes, there could be an underlying osteomyelitis, a pyogenic osteomyelitis could be there, which would have flared up the actinomycotic osteomyelitis, thus creating a symbiotic association between these two, and thus causing this lesion. This could be, but I could no way prove that it could have a pyogenic lesion and then leading to an actinomycotic. Yes, ma'am.
Vinila, can I ask you what you want to ask me? Okay. I personally believe that these were not actinomycotic osteomyelitis of mandibular or oral cavity. As Dr. Mariam said, they started with normal pyogenic osteomyelitis and they were secondarily infected by actinomycosis.
Yeah, ma'am.
So you can't call it primary actinomycotic osteomyelitis, isn't it?
Yeah.
Because any osteomyelitis, when it spreads so far, generally we carry out mandibulectomy or hemimandibular or maxillectomy. They replace this with a lot of nowadays so many implants are available, so we can replace the bones very easily. So this is a secondary infection of actinomycosis on already present osteoma.
But how do I prove that there was a
I mean, I can understand. Yes, sir. Surgeon, I can.
Yes, sir.
It was there.
Yeah, it was there. Yeah.
Because I have come across quite a few cases like this.
Okay, sir.
And I have treated, but we never labeled them as actinomycotic
Osteomyelitis. Okay.
So you have to be very specific.
Okay.
If you find only actinomycosis and no bacteria, then you can call it actinomycotic osteomyelitis.
Yes.
But in mouth, it is not possible.
Yes, sir.
Mouth is the dirtiest part of the dirtiest part of the body. So there are so many bacteria.
Yes, sir. Absolutely.
So I think that could be the proper diagnosis.
Yes.
Thank you very much.
Thank you.
For your
Multiple sinuses occur in the dental pathology also.
Also, yes.
Many times we see such eroded bone right from first premolar on one side to second premolar on another side.
Yes.
And you can see the picture like osteomyelitis, but truly it comes out to be the big cyst,
Yes. I have somebody. Yes, ma'am.
Thank you so much for a very great presentation. I'm a gynecologist, and actinomycosis has been recently described causing like severe appendicitis that looks like malignant-like appearance with marked fibrosis, and it's related to actinomycosis. Also, cases, and in a recent conference I attended, and there was an actinomycosis causing severe ulceration and the perforation of the colon, and there was no other reason. it was only an invasive actinomycosis that caused a perforation and even gave like a malignant appearance on radiology. And at the end, the diagnosis was so it's like very interesting that we thought like this actinomycosis infection is not violent, but it is.
It is, yes, it is.
Yeah.
It is.
So, thank you so much.
Thank you. Thank you so much for the update. Thank you, ma'am. I'll have that. Last one, sorry.
Thank you for your presentation.
Thank you.
I am a digital pathologist and I do practice in Saudi Arabia, Eastern region. And I have my residency in the United States. So we do go across these cases frequently in the United States and in Saudi Arabia. And usually to diagnose them as osteomyelitis, we have to see that bacterial colonies. But my question is, did you see any bacterial colonies other than the actinomycosis?
Yes, ma'am. In one case, we have seen the bacterial colony. In one case, we have seen, but the rest of the two cases, we just got the biopsies. After that, the whole bone didn't come to us. We just got the biopsy. If had the whole bone had come to us, we would have given a decal bit and then we would have looked for it. But it was the only initial diagnosis had come. After that, the research, because we are a medical college of the where we had only limited resources. After the surgery, and that whole surgery will go to the Apollo Hospital's main Apollo, where they do the corporate Apollo, where they have the big bang of all the facilities available. So the bone had gone to them. So we can't retrieve from their bank of histopathology. So we just left it maybe. But one case of we had a pyogenic bacterial colony. Yes, ma'am.
Okay. And I think to say that this is primary or secondary, we usually rely on the scooping of the bone. So if there is the bacterial colonies, rely on the bone and there's a scooping within that bacterial colonies. So I think one of the histological cases that you presented, I saw some scooping on the bone.
Yes.
Beside the actinomycosis. So I would say that this actinomycosis caused that osteomyelitis in this case specifically.
Oh, thank you. I'll keep that in mind. Thank you so much.
Thank you very much.
Yeah.
For your great presentation. The next speaker is Dr. Rajan from UAE. I'm passing her the stage to deliver the speech on overview of medical renal diseases.
Please be here because it's recording. Okay. Yeah. Yeah, it's okay. We can just move. Okay. Thank you.
Good morning once again, everyone. Till now, we were seeing research articles, posters, papers, and all. Now there is a little change. We'll be having a learning interactive session that is overview of medical renal diseases. It's just going back to your postgraduate life. That's what. It's just we are learning together. So yes, this is overview of medical renal diseases. So today's objective is indications of renal biopsy, correlating clinical and histopathology of renal biopsy, and interpretation of renal biopsy. That is how to approach a renal biopsy, how to read it. So coming to the indications of renal biopsy, it is nephrotic syndrome, acute renal failure, chronic renal failure, hematuria, and asymptomatic proteinuria. Coming to the complications of renal biopsy, it is the macroscopic hematuria. It's usually the most common complication is hematuria. Usually the patient develops hematuria after a few days of the biopsy. And next is the hemorrhage into the retroperitoneal tissue around the kidney. Then coming to the types of renal biopsy specimen, one is a percutaneous specimen, then transjugular specimen, and the wedge biopsy specimen. Transjugular specimen is usually done in high-risk patients where percutaneous is feasible or contraindicated. And the contraindications of renal biopsy include uncorrectable bleeding diathesis, uncontrollable severe hypertension, active renal or perirenal infection, and skin infection at the biopsy site. Now about handling of renal biopsy. So ideally, we should ask the clinician to at least have 3-core renal biopsy of approximately 10 millimeter or more in length. If it is not possible, at least 2. Sometimes the clinician is having difficulty in getting a renal biopsy. The 1-core biopsy can be divided into 3 parts. So we should ask them to put 10% in 10% formalin for light microscopy and for immunofluorescence, and for electron microscopy, it is 2% glutaraldehyde. So if you are getting only 2 biopsies, core biopsies, one is exclusively for light microscopy and the second one for immunofluorescence, and either you can cut both half or you can cut 1 to 2 millimeter of both the edges for electron microscopy. And remember, you should put always in 2% glutaraldehyde. You have to advise the clinician do that, not put in formaldehyde. Now coming to the clinical manifestations of renal diseases. So before going to see the biopsy through light microscopy, you need to have the clinical history and lab investigation and get a differential diagnosis. So the minimum history that is required before interpreting biopsies, the age of the patient, then the onset, whether it is a rapid onset or an insidious onset, how long the patient was having disease, and the presenting complaints like whether the patient is having any symptoms of rheumatoid arthritis, SLE, and past history of hypertension, diabetes mellitus. So all this we have to take in detail. You have to ask the clinician to tell the history in detail. Then the minimum investigation before interpreting the history is, main thing is urine routine. Not just the laboratory technician be giving just RBC 1+2+. No, we have to know whether there is dysmorphic RBC or isomorphic RBC. Dysmorphic RBC is seen in upper urinary tract pathology and isomorphic is seen in lower urinary tract pathology. So that we have to see clearly. Then a 24-hour urine protein. If the patient is not ambulatory, you can use a spot urine protein or the creatinine ratio, that is otherwise known as spot PCR. And if the patient is having nephrotic or nephritic syndrome, for that you need to know the serum albumin or cholesterol level. Then the renal function test. Main thing is creatinine level. Just not the single creatinine level, you should know the percentage rise in the level of creatinine. Then ultrasonograph, and optional findings are viral serology, ASO titer, ANA, dsDNA, and all, to know which specific disease the patient is having. So now how to approach a renal case step by step. As I said, the clinical history is very much important for reading a renal biopsy specimen. So you have to read the clinical history thoroughly. You have to deal what type of renal problem you are dealing with, whether it's a renal failure, there is rise in creatinine, whether it's an acute onset or a chronic onset, whether the patient is having nephrotic syndrome or a nephritic syndrome. Then you have to see whether do you have any other clinical details where you can add to get the diagnosis. Like as I said, the age of the patient, other symptoms like arthralgia, rash, and all, to check whether it is a rheumatoid arthritis or an SLE. Then you have to see the microscopy, that is light microscopy, immunofluorescence, and electron microscopy. Now you have to make a morphological diagnosis, what pattern you are seeing in the light microscopy, whether it is a single pathology or single pattern you are seeing, or there are several morphological findings you are seeing in the slide. Then you have to fit together the clinical picture plus the morphological finding. If they are not fit together, think again, are you misinterpreting the histology? Then the last point is there anything more you would ask for to help the clinician, then you can add as a comment. As I said, first is reading about the history. So the lab investigation, when will you say there is significant proteinuria? If it is more than 150 milligram per 24 hour, you say it as significant proteinuria. And if it's less than 3 gram per 24 hour, you say it as subnephrotic proteinuria. Then about nephrotic range proteinuria, that is more than 3 to 3.5 gram per 24 hour or more than 40 milligram per meter square per hour, or says sport urine PCR, that should be more than 2. These are the lab investigation, at least that you should keep in mind. Now, when will you say that there is nephrotic syndrome? There should be proteinuria, hypoalbuminemia, generalized edema, hyperlipidemia, and lipiduria. Generalized edema is the most obvious clinical manifestation. So these symptoms you have to keep in your mind. Then when will you say it is acute renal failure? When there is a sudden episode of kidney injury, happens within a few hours or a days, you say it as acute renal failure. When you have to think about the etiology, you have to exclude the pre-renal and the post-renal cause. It should be a renal cause. That is, it can be of acute tubular injury, acute interstitial nephritis, glomerulonephritis, etc. Now about nephritic syndrome. There the patient will be having hematuria. How? There will be red cells or the red cell cast in the urine. As I said, you can say whether it is dysmorphic RBC, it will be upper urinary tract pathology. If it is isomorphic RBC, it is lower urinary tract pathology. Then proteinuria. Usually in nephritic syndrome, there will be subnephrotic range of proteinuria. There can be edema, or edema can be present or no. Then azotemia and hypertension. Now, another entity is rapidly progressing glomerulonephritis. That is rapid deterioration of the renal function within 2 weeks or 3 months, but the kidney size will be normal here. And the characteristic finding is presence of crescents, which I'll be telling in detail. Before going into everything, I will show you how to read a glomerular histology. So here, am I audible? Yes. So here you can see the Bowman's capsule. And here you can see the glomerular duct. You can see here the glomerular basement membrane. So glomerular basement membrane is always better to see at the periphery. If you see in the central, you will not be able to appreciate it properly. So the glomerular basement membrane is ideally to compare the thickness with the tubular basement membrane. So tubular basement is better to do in a PA stain than a HNE stain. So this is the glomerular basement membrane. In that you can see the flag cells, which is the visceral podocyte. Opposite to that, you can see the Bowman capsule, where you will see the parietal epithelial cell. So in between the glomerular basement membrane and the Bowman's capsule, there is a space where you see actually the parietal podocytes. The peripheral podocytes are on the Bowman capsule, as I said. Then you can see the small loops here, which is the capillary loop, where you can see round blue cells, which are the endothelial cells. So when you see there are a lot of capillary lumina, in between that you can see some eosinophilic matrix. There you can see blue round cells. These are the mesangial cells. So this is the normal histology of the glomerulus. Now, how to approach a renal case histologically? So as I said, first is clinical history, second is lab investigation. Now you have in mind a lot of differential diagnosis. Then you have to look at the microscopy. What morphological finding you are seeing? What are the patterns that you're seeing? First, you have to see the HNE, then special stains like PAS, silver, Mason's trichome, and option 1 is Congo red, which is usually done in amyloidosis. Then direct immunofluorescence and electron microscopy. So first you have to start with the low power. How many cores are you seeing? Whether you are seeing cortex or medulla, or you are seeing both in that. Are there any widespread tubulo-interstitial changes? Whether the normal cortical tubules are in back-to-back pattern. If not, is there any interstitial expansion that is mainly due to fibrosis, edema, or it can be due to inflammatory infiltrate? Then you have to go to the high power systematically. First the glomeruli, then the tubules, then the interstitium and the vessels. So this is how a core biopsy will look histologically. First, as you said, you have to see systematically from glomeruli, tubules, interstitium, and the vessels. So when you see first, you have to count the number of glomeruli. Why, I will tell you. So there is one calculation about global glomerular sclerosis. How will you calculate? First, you have to know the age of the patient. Supposedly, the age of the patient is 80 years old. You have to divide it by 2. Then it will be 40 minus 10. So 30% sclerosis can be seen. Then I said the glomeruli, you have to count the number. Is there any hypercellularity? As I showed in the mesangium, there were 2 to 3 cells. Normally, you can see in the mesangium. If it is more than that, it is hypercellularity. So it's better appreciated in PAS stain. Then is there any endocapillary proliferation? Cells in the capillary lumen are usually the lumina, as I showed in the histology, you could see the lumina properly. If there is endocapillary proliferation, so within the capillary wall, is there any, normally the capillary wall does not contain any cells. So is there any membranous proliferative pattern? Or there are crescents. As I said, crescents are usually extracapillary cells that are seen in the Bowman space. And is there any capillary wall thickness? If thickened, it's mainly appreciated in the PAS or the silver stain. You can appreciate as double contour or spikes and holes. Is the mesangium expanded? If so, is there any nodules? Is there any extraneous substances like amyloid, immune complex, or light chain? Then you should look carefully for segmental scars, thrombi, and necrosis. Now, as I said, when you get a core biopsy, you have to count the number of glomerulus. Why? Because supposedly this is a normal looking renal biopsy. In that, only one of the glomerulus is affected. Only one of the glomerulus is affected. It is focal. If all the glomerulus is affected, it is diffuse. And in the glomerulus, or if the glomerulus is fully affected, it is global. Only this portion of the glomerulus is affected. It is segmental. So this is diffuse and global, and that is focal and segmental. That is why I said it is important to count the number of glomeruli. Now coming to the tubules, you have to see the percentage atrophy of the tubules. You have to have the evidence of any tubular damage like dilation, epithelial flattening. Is there any presence of cast, mitosis? Is there any inflammation? And in cast, you can have to see whether it is any granular cast, eosinophilic fractured cast, which is seen in myeloma, and neutrophilic cast, which is seen in acute pyelonephritis. And is there any crystals? Mostly oxalate crystals can be seen. Then coming to the interstitium, is there any presence of edema, fibrosis, inflammatory cell infiltrate, or hemorrhage? And arteries, you have to see the intimal thickening, thrombosis, necrosis, vasculitis, inflammation, and cholesterol emboli. Now coming to the special stains, first is PAS stain. In glomeruli, you have to see any GBM thickening is there. You can appreciate in PAS stain, irregularity or double contouring rupture. Is there any fibrinoid necrosis? Amyloid is weakly PAS positive, and hyalinosis and sclerosis are PAS positive. Tubules, you can appreciate the basement membrane thickness. Vessels, arterial hyalinosis and fibrinoid necrosis can be appreciated in fibrinoid periodic acid shift stain. Now coming to silver methamine stain. So GBM thickening changes can be, you can appreciate in silver stain is holes and spikes, reduplication, that is known as tram track appearance, tuft breaking. Then how to distinguish hyalinosis and sclerosis. Hyalinosis and sclerosis were positive in PAS stain, as I mentioned, but in silver stain, you can appreciate that it will be silver negative in hyalinosis, whereas sclerosis, it will be both PAS and silver positive. Presence can be easily recognized in silver stain. Silver negative will be in immunocomplex amyloid. So this is a normal looking glomerulus. There you can see in the mesangium, there are increased number of cells. And here it is the endocapillary hypercellularity. You can see the lumina is filled with endothelial cells, and that is a segmental sclerosis appreciated in the PAS stain. So our light microscopy, HNE and immunofluorescence is, special stain is over. Now coming to immunofluorescence. In immunofluorescence, you can see immunoglobulin heavy chains, IgG, A and M, light chains kappa and lambda. If it's complement fragment C3, it's a common, all pathways are affected. If it is C1q, the classical pathway is affected. Then you have to give which pattern you are seeing, whether you are seeing a granular pattern or a linear pattern. Linear pattern is seen in anti-GBM disease, or it's a smudgy, for example, in fibrillary glomerulonephritis. Then you have to see whether you are seeing in mesangium or a capillary wall. Then you have to give the intensity from 0 to 3+. So this is can anyone say what is this? Where you are seeing positivity? Yes, and it is a linear or granular? It's linear or granular? Linear positivity. And this one, it's a granular positivity. Now, how to look at the biopsy through electron microscopy. So the glomerular tuft, we can see this. This is the GBM membrane. These are the endothelial cells. Sorry, epithelial cells. These are the endothelial cells. And here you can see the mesangial matrix. And in between that, you can see the podocytes, food processes. Okay. Now I have going to glomerulopathy according to the morphological pattern. One is non-proliferative pattern, where there is no proliferation at all, then proliferative and crescentic. Coming to non-proliferative glomerulopathy, in that it is minimal change disease, focal segmental glomerulosclerosis, membranous nephropathy, and diabetic nephropathy. So the podocyte is affected in mainly in the non-proliferative disease. Otherwise, they are known as podocytopathies. So where is the podocyte affected? If there is no change in the podocyte number, you call it as minimal change disease. And if their podocyte number is reduced, we say it as focal segmental glomerulosclerosis. If it is increased, the podocyte number is increased, we say it as collapsing glomerulopathy, which is a variant of focal segmental glomerulosclerosis. Now, it's an interactive session, as I said. After that, you can answer what is the diagnosis. So, first case, it is a 65-year-old Caucasian woman with a past medical history of hyperlipidemia, presents with acute onset swelling in leg for 2 weeks. Creatinine is 1.1, albumin is 1.8, urine protein creatinine ratio 8 grams. Secondary workup is pending at the type of biopsy. From the clinical history, what is your diagnosis? Whether it is a nephrotic syndrome or a nephritic syndrome? Nephrotic syndrome. Yes, the nephrotic syndrome usually non-proliferative, present as nephrotic syndrome. So what all are there in non-proliferative? Minimal change, focal segmental, membranous, and diabetes mainly. So here in light microscopy, PAS, there is no GBM thickening. Here you can see there is no mesangial cellularity, no endocapillary cellularity. Tubules are looking normal. Light microscopy, there is not much change. Everything looks normal. Immunofluorescence you are doing, it is negative. Immunofluorescence is negative. And when you are seeing the electron microscopy, you can see there is placement of the food processes. What is the diagnosis? Minimal change disease. So minimal change disease, etiology, it can be due to idiopathy, genetic form, and secondary form. Idiopathic exact mechanism is not known. There is decrease in nephrin adhesion molecule in podocyte food processes. And genetic form, it's a congenital nephrotic syndrome of Finnish type. Here, the mutation is in the nephrin gene mutation. And the secondary, which is a drug-induced, it can be due to NSAIDs or it can be due to neoplastic diseases. It can be due to infection also. It can be due to autoimmune causes. And it is the most common cause of nephrotic syndrome in children. Prognosis is 90% of the children are steroid sensitive. Complete resolution of proteinuria can be obtained. Minority can develop steroid dependent or steroid resistant. Adults are usually slower to respond, but they have a long-term prognosis is excellent. So non-proliferative is over. Now coming to proliferative glomerulopathy. These three entities are just the morphological patterns. It is not clinical diagnosis. Membranoproliferative, diffuse proliferative, and mesangial proliferative. Diffuse proliferative, you see mostly we can see in a pro-streptococcal infection, C3q glomerulopathy. Membranoproliferative, you can see in IgA nephropathy, lupus nephritis. Even mesangial proliferative, you can see in lupus nephritis. So coming to the case 2, male 55-year-old is a known case of Hodgkin's lymphoma. It's a nephrotic presentation. Creatinine is 150. Then urine protein to creatinine ratio is 1000. Albumin is 20. ANCA, ANA, hepatitis, Hep C, all, no paraprotein is detected here. So as you know, the patient is having Hodgkin's. So some secondary glomerulonephritis, and the patient is presenting with nephrotic syndrome. So here you can see actually the GBM thickening is present. And when you see the silver stain, you can see holes and spikes. So from here only we can get a diagnosis. Membrane. Yeah, it is positive. And here you can see the subepithelial deposits here. So it is nothing other than membranous glomerulonephritis. So most common cause of nephrotic syndrome in adult. And most common type of glomerulonephritis that is associated with malignancy in adults. So as I said, it can be of primary or secondary. Primary can be due to idiopathic, due to the phospholipase A2 receptor. Then congenital forms are associated with the MMF antibodies. Secondary, it is infectious, can be hepatitis B, C, syphilis. Then autoimmune diseases like lupus, rheumatoid arthritis, thyroiditis, neoplastic process, graft versus host disease. So now coming to crescentic glomerulonephritis. It is a rapidly progressing glomerulonephritis. Ultrasonographically, the kidney size will be normal. It's a rapid onset. The rapid loss of renal function happens. On histologically, you can see crescents, and crescents are nothing but 2 or more layers of proliferative cells in the Bowman space. But when you have to say it's crescentic, there should be more than 50% of crescents. If there are like 10%, then you cannot say it as a crescentic glomerulonephritis. Crescents can be seen in all proliferative pattern also. If you see it more than 50%, you say it as crescentic glomerulonephritis. So coming to case 3, female 39, blood and protein in urine, creatinine is 195, swelling in hands and feet. So what is it? It's a nephrotic nephritic syndrome. And it's rapidly progressing. So here what you can see in the histology, you can see here mesangial proliferation. You can see endocapillary proliferation also. Mesangial proliferative, even the membrane is thickened in special stain. You can see sclerosis also. It is positive, and you can see IgA is positive here, and you can see in the paramesangial and the mesangium there is deposits. IgA is positive in which membranoproliferative disease? IgA nephropathy. So it's the most common glomerular disease worldwide, common in Asian population and rare in Black. It's increased serum level of poor galactoside IgA1. So it can be due to primary following a urinary tract infection, or it can be due to secondary. Most common cause is chronic liver disease. So it's a common type of glomerulonephritis associated with chronic kidney disease. And you score it by Oxford classification, whether that's mesangial proliferation is there, endocapillary proliferation is there, crescents are present, tubules are present or not. That's how you classify the IgA nephropathy. I've just when a overview of the renal diseases to make it interesting. I have not went to complicated cases. That's all. Thank you. Yes.
Thank you, Doctor, for this nice presentation of this interesting subject in pathology. Most of the pathologists are aware and try to get away from such biopsies because it is so needs sophisticated investigation. I have a couple of questions. Some of them are practical. Number one, do you ask or do you prefer to use the kappa lambda immunofluorescence routinely in immunofluorescence assessment?
Not routinely, we are not doing. If there is, as I said, we'll go through clinical investigations, that the history is there, then only we are doing in our place routinely. Actually, we are not doing in our hospital, but we refer that. But only when there is clinical history is there for monoclonal gammopathy, then we ask for kappa lambda. Routinely, we are not.
In suspected cases.
Yes, yes.
The question number two, what's the preferred preservative for immunofluorescence samples?
It is 2% glutaraldehyde. Immunofluorescence, oh sorry, immunofluorescence, it's formaldehyde only.
Formaldehyde?
Yeah, 10% formaldehyde. Oh, we can put in saline also, but here we are putting in formalin. For saline. It's better to do in saline.
Yes, you know, roughly we are doing the cross-section samples for immunofluorescence assessment. So they prefer to use saline or I think what's it called, zinc or Mitchell signal.
Mitchell signal, yeah. But actually we can see 10% formal. I don't know whether you people have done it, but we are routinely doing that.
Question number 3. I'm sorry for this long list of the IgA scoring system.
Yeah, it's Oxford classification.
What?
It's Oxford classification.
What about Haas classification?
Yeah. Oxford only.
Oxford is more renowned.
Yes.
Okay, thank you.
Thank you, thank you.
Thank you for great presentation. Our next speaker is Dr. Karshi Rao from India, and passing her the stage to deliver the speech on HPV association of squamous cell carcinomas of cervix in Indian scenario.
Can you use this one? Yes, I did. Yeah, okay. It's not yours. This is mine, the one which I just made. So I will use the stage. Yeah, you can. But be please, because it will be okay. Yeah, I can.
A very good afternoon to all, and thanks to the chairpersons. I'll be presenting on HPV association of squamous cell carcinomas of the cervix in the Indian context. Very good afternoon to all, and I'll be presenting on HPV association of squamous cell carcinomas of the cervix in the Indian context. And I'm an additional professor in Department of Pathology and Lab Medicine at AIIMS Jodhpur. And the purpose of this presentation is, all of us know now, to diagnose just squamous cell carcinoma of cervix is not enough. And we have to tell whether they are HPV independent or HPV associated because of prognostic differences. So cervical cancer is the fourth most common cancer in women globally, and the second most common cancer in women in India. Almost 2 to 3 decades back, it was the most common cancer in females, but now breast cancer has overtaken cervical cancer. And approximately 90% of the cervical cancers occur in low and middle income countries that lack systematic screening and immunization programs against human papilloma viruses. And in India also, we are not having, at least in our the area where our institute caters to, screening programs for cervical carcinoma. It's only the patients who are coming to the OPTs who are getting screened for cervical carcinomas. So all of us are familiar with the risk factors of carcinoma cervix. That is the first age of intercourse, multiple sexual partners, increased parity, male partner with multiple sexual partners, persistent detection of high-risk HPV, exposure to nicotine, and other coexisting infections like chlamydia and HPV. And it is in the fifth risk factor that we are interested in. And a brief word about human papilloma viruses. Now, they can cause benign papillomas and they can cause benign genital wart, as well as their risk factors. The high-risk HPVs are risk factors for malignancies of head and neck, especially of the tonsillar area, squamous cell carcinomas of the cervix, anogenital region, and as I said, the head and neck cancers. And most of the HPV infections of the cervix are asymptomatic, and it is at its peak in the 3rd to 4th decade, and after 30 years of age, it declines. And fortunately, most of the infections are cleared by 50% are cleared by 8 months, and 90% within 2 months. Only around 10% persist, and of these also only 10% progress to low-grade squamous intraepithelial lesion, and of those also only further 10% progress to high-grade squamous intraepithelial lesion. So in that way, it's the persistent HPV infection, which is especially with high-risk HPV, which is a risk factor for development of carcinomas of cervix. The difference between benign warts and carcinomas is that the HPV genome is maintained in non-integrated episomal form in the benign warts, and in the carcinomas, it is integrated in the host genome. The viral integration is random, but the pattern of integration is clonal. And how the HPV causes carcinoma is that the virus disrupts the E1, E2 open reading frame, and the HPV proteins E6 and E7, they interact with P53 and retinoblastoma respectively. So the oncogenic activities of HPV E6 are that it binds to and mediates destruction of P53, which is the guardian of the human genome, as we are all aware of. And it also stimulates expression of telomerase reverse transcriptase. Therefore, the cell becomes immortal. The oncogenic activities of E7 is that it carries the cell over the G1S cell cycle checkpoint by binding to the retinoblastoma protein. And also it activates the CDK inhibitors P21 and P27 and activates cyclin A and E. So this is just a diagrammatic representation of the same. And other co-infected mutated RAS gene has also been implemented in increased chances of development of carcinoma cervix, apart from the environmental factors like smoking, diet, and coexisting infections like HIV, etc. So this is just to repeat that the purpose of the screening program is that the intraepithelial lesion is there for a long time. And only a few of the high-risk HPV infections, they progress to HSIL. And out of HSIL, also the latent period is almost as long as 10 years. So if we have a good screening program, we can pick these lesions at an in situ stage where it is non-invasive. So the current study, it was approved by the Institutional Ethics Committee, and informed consent was taken from all the patients. It was performed from 2018 to 21, and biopsy diagnosed cases of squamous cell carcinomas were included in the study. Any patient who had received radiotherapy or chemotherapy for any other disease was excluded from the study. And all the specimens were fixed in 10% neutral buffered formalin, and paraffin blocks were prepared using routine histopathological techniques. The sections were cut at 4 to 5 microns and stained with HND stain. The representative blocks were selected for immunohistochemistry for P16, and P16 was used as a surrogate marker for HPV infection in the current studies. So the study was done on 50 cases of SCC. The age of the patients ranged from 33 years to 81 years, with a mean age of 56.28 years. So this is the age distribution curve. Maximum number of patients were in the age group of 60 to 70 years, 65 to 70 years actually. And the mean age was 56.28 years. So that's quite a young age. If we look at the mean age, that's 56 years. Tumor grade is actually no longer indicated in carcinomas of the cervix, but still many of the clinicians ask for it. And the reason being that the grading is based on the keratinization of the tumors. And all of us know that HPV-associated tumors are usually non-keratinizing, and they have a good prognosis. So if we go by the prognosis based on the grading, it's the keratinized tumors which are well differentiated, or grade 1, which would have a better prognosis, but that is not true for SCC of the cervix. So WHO specifically states that grading is actually redundant, but still some of the clinicians ask for grading of cervical squamous cell carcinomas. So although it's redundant, we did perform the grading in the current study. So 80% of the cases were moderately differentiated, that is grade 2, and 8 out of 50 cases, that is 16%, were poorly differentiated, and only 2, that is 4% of the cases, were well differentiated or grade 1 squamous cell carcinomas. This is just depicted in the so majority of the cases were moderately differentiated. Tumor necrosis was seen in 30% of the biopsy samples, and associated dysplasia or high-grade squamous intraepithelial lesion was seen in 46% of the biopsies. When we performed P16 IHC, taking block type of diffuse positivity as positive staining, almost 94, almost just barring 3 cases, all were positive for P16. So majority of the cases were HPV associated. In addition, we also did a tumor infiltrating lymphocyte grading because increased number of TILs, it has been shown they have a better prognosis in cervical squamous cell carcinomas. So if we see the TILs, none of the cases had less than 1% of TILs. So that means this is considered as negative or absence of TILs. 11 cases had TILs between 1 to 10%. 16 cases had 11 to 25% of the TILs. 13 cases between 25 to 50%, and 10 cases had more than 50% of TILs. Very robust immune response in these cases. If we see the HPV association, and although the case number is very low, we had just 3 HPV independent cases of squamous cell carcinomas. 1 case of HPV independent SCC had more than 50% TILs, but 19.14% of HPV associated cases had more than 50% of the TILs. And if we see the number of TILs in the 1 to 10% groups, the other remaining 2 HPV independent SCCs had this amount of TIL. And but there was no significant association. As I said, the case number was very less for significant statistical association. So this we have already. And another thing that was noted is that the TILs, the number of TILs was more in cases where there was no necrosis. So possibly relation to the better prognosis with the presence of TILs. Another study by Ming-Fen et al. Also found that increased number of TILs, the lymphocytic infiltrate, was related to definite tendency and longer survival of the patients. And none of the HPV-associated SCC showed keratin pearls, which is again emphasizing that the grading is redundant. Even in our study also, none of the cases which were HPV independent showed HPV-associated showed presence of keratin pearls. Show the images. So this is a squamous cell carcinoma of the cervix. This is a low grade and this is a high grade, and we can see numerous tumor infiltrating lymphocytes in this case. And we do not see any evidence of keratin pearls. Again, very robust immune response. We can see all these are the tumor islands, and these blue cells are the lymphoid, the tumor infiltrating lymphocytes in the tumor. Same case, this is the P16 immunohistochemistry, and we have to be careful that the positivity has to be both nuclear, cytoplasmic, diffused, block type of positivity to be called positive. So low par, high par, this inside is showing the high par. So this was P16 positive, and it was an HPV associated squamous cell carcinoma. Another case, we can hardly see the tumor cells. So such a dense lymphoplasmacytic infiltrate, we can hardly see, resembles lymphoepithelioma like carcinomas of the bladder, of the head and neck. Very robust immune response in this case. Again, it was HPV associated, diffuse block type positivity for P16. This is a case of this is a squamous cell carcinoma. We can see keratin pearls also, keratin pearl formation. So this was keratinizing SCC. However, it was HPV independent. No P16 positivity noted in the case. So the conclusion, 94% of the cases in the study was HPV associated, and overall the world literature also states that up to 90 to 95% of squamous cell carcinomas of the cervix are HPV associated. We did not do any in situ hybridization in the current study. It was done on the basis of P16 being used as a surrogate marker for, since most of the cases are HPV associated, with further lays emphasis on a robust screening program for carcinomas of the cervix. So in Indian context also, we found that almost 94% were associated with HPV. So if we have a good screening program, cervical screening program, which is mostly based on cytology and HPV testing, most of these carcinomas can be prevented. Thank you. I'll be happy to answer any questions.
Thank you, Director, for this presentation. I have a single question regarding cervical cancer is one of the preventive tumors. About the screening method, some say that we can rely on HPV, high-risk HPV assessment for screening.
Okay.
Can we postpone pap smear in such a condition?
Recommendations say we have to do dual testing now. The current recommendations, they go for dual testing, both the cytology and HPV testing together. So depending, there's a proper flow chart. The guidelines are there, depending if one test is positive and one is negative. So guidelines say, but actually we can go either for cytology alone or HPV testing also.
So co-testing.
Co-testing is the current HPV co-test. So dual testing, both cytology and the current recommendations say we have to do both HPV testing as well as the cytology.
Thank you.
Excuse me, ma'am.
Yeah.
Okay. Categorize your STCs, carcinoma, and differentiate the well-differentiated or moderate differentiated or poorly differentiated?
Yeah, we didn't want to. Like I said, it's not indicated now, but clinicians still do ask for the grading.
And another question is, did you categorize STC, early invasive STC or micro-invasive STC?
No, we actually, in most of the cases that we got were fragmented biopsies. And in, like I showed, only a few of them had in situ or HSIL. So cases which did not show HSIL, and we are just seeing fragmented bits which are showing invasiveness. So if we do not see the connection with the overlying epithelium, it's very difficult to say whether it is microinvasion or the depth of invasion is very difficult.
In head and neck region, when we talk about the city, when we say we see keratin pearl in section, we know it's similar to well differentiated. You say that all of your HPV associated didn't have any keratin pearl. So all of your sections was poor differentiate that?
No, most of
We
them.
can say it in cervix or it's the independence.
We did see some amount of intercellular bridges, individual cell keratinization. So because of that, we could say that they are moderately differentiated. But none of the HPV associated SCC showed keratin pearls. So none of the HPV associated were well differentiated. But like I said, the grading is actually not at all indicated in squamous cell carcinomas of the cervix. It is not indicated at all. Because like I said, it's grading. So if you see by this current grading system, the well-differentiated one should have a better prognosis, but they are associated with, they are HPV independent. So actually they're having a bad prognosis. So no grading of squamous cell carcinomas of the cervix. Yeah. Yeah, that is it. Whether it is HPV associated or independent, that is dependent. Yeah. Okay.
Yes. Do you have vaccination policy in India for cervical cancer?
Yes, sir. They were.
Have you started vaccinating girls?
Yes, sir. So we have started. The age is 14 to 26 years, and we are not vaccinating women above the age of 30 years because it's like by the age of 30 years, most of the women have been infected with HPV.
And what about boys?
So boys, we don't have any current policy, only for girls in India. That too between the age of 14 to 26 years.
Madam.
Yes, sir.
I'm Dr. A from India. And
Morning,
my
sir.
question exactly was what I suppose Dr. Subal Nanavati asked you is about the recent vaccine that the government of India has come out with.
Yes, sir.
What is your opinion on the efficacy of it?
Sir, thank you, sir. Sir, the recent nanovalent vaccine, earlier there were Savarix and Gardasil, and the advantage of the newer vaccine is that it is covering most of the high risks in one single vaccine only. And the number of doses is also less. But sir, currently we don't have the experience. I mean, the follow-up. So that is the newer vaccine, which is initially we had just two vaccine with the, so now all the high risks HPV are included in this nanovalent vaccine. And we just have to give 2 doses. Only 2 doses are required. But I'm sorry, I don't have any clinical experience with the vaccine. Yeah. So that is the newer vaccine. Okay. It's got the advantage of all the high risks being included and lesser number of doses. That is the advantage.
Thank you for your great presentation. Oh, it's okay. Thank you so much. Right. We will now move ahead for photo session. Networking at launch, we will need to be here at 30:50 to start the conference session again. This one, right?
Our next speaker is Dr. Rina Phelan from India. I'm passing her to say the delivered speech on pathology finding out.
Yeah, yeah. Thank you, Priya. Yeah.
You can use this one if you want, you can stand there.
Yeah, thank you.
Please.
I'm quite audible. Sorry to bother you before lunch. I just wanted to wrap it up and have it in peace. Lunch, have it in peace. So my next topic is pathological findings of Whipple's pancreaticoduodenectomy, a single center experience. This was a quite challenging task for me because I was involved with the institute from the beginning since 10 years. So Whipple's was never my zone of grossing, especially grossing, because I never understood what does margins mean, what does surfaces mean. When they tell it, it's different. And when you start cooking it or doing it yourself, it's totally different scenario. So it was all a different scenario for me to start with. So I thought I'll take up this case as a challenge to myself, how I'm going to do this presentation. So coming to the introduction of Whipple's, Dr. Alan Oldfather Whipple in 1935 did the surgery as a two-step procedure. Then subsequently, he's done it as a single-step procedure. Whipple's usually involves any of the tumors involving the head of the pancreas, the part of duodenal carcinomas, any kind of bile duct, common bile duct malignancies, the ductal malignancy, the pancreatic, pancreatic ductal malignancies were involved. Proper grossing orientation is very, very important. Proper grossing techniques is very important. Telling the margins is important. The surfaces is important in the CAP protocol. And also the latest, that is the orange peeling of the lymph nodes, is very important to give a prognostic significance of this lesion. So the factors which we include is the tumor location, tumor extension, tumor size, then surgical margins, vascular perineural invasion as all tumors, and then we have the lymph nodal status. This was also a retrospective study, but when I had this case being done by me, all the 5 cases, I already had in mind that I will do this as a presentation. So each case was a bit challenging for me. We had only 5 cases in the 5 years. So the first case, we had it in 2018. All of them were males except one female, which was young. She was a very young female, around 42 years old. So all the cases were done for malignancy. I'm not going to go into each case as such. I thought I would emphasize before lunch on the grossing techniques and the pathological findings. Coming to that off, there are 2 types of Whipple's surgery. That is the classical Whipple's procedure, and then we have the pylorus preserving Whipple's surgery. In the classical Whipple's surgery, they remove the common bile duct. Then we have the head of the pancreas. Then we have the whole of the duodenum. Usually it is whole of the duodenum with 1 to 2 centimeters of the jejunum. And they also do the lymph nodal peeling, which is called as orange peeling. Just like how you remove the orange peel, like that we peel the lymph nodes. And what is so important about it is we usually do the lymph nodal peeling before doing the grossing of the Whipple's sample. So coming to that of how do you know which is what? There are only 2 surfaces. You have many margins. That is, you have 6 margins when you do a Whipple's. And how do you differentiate between a margin and a surface? Whenever we say a margin, it is always the surgical resected part is called as a margin. And when we say it is a surface, it is the normal anatomical surface. So as such, when the specimen is totally being resected, we have a proximal resected, which can be a gastric margin or can be that of a duodenal margin. And we have a distal resected margin, which is usually a small intestine, that is the jejunal margin. So the proximal resected margin, the distal resected margin are the 2 margins we have. Then we have another margin called as the pancreatic neck margin. Why do you call it as pancreatic neck margin? Because the pancreatic head is being separated from the neck. So we call it as pancreatic, which is being created by the surgeon. So that's the third margin we have. Then the fourth margin as such is called as uncinate margin. And this is not a true margin because you don't have a cut here by the surgeon. Why do you call still as a margin is nothing but when they cause the separation of superior mesenteric artery dissection, they create a small, very sharp indent on the surface of the uncinate. So that's being created by the surgeon as a sharp indent on the uncinate surface. So because it's created by the surgeon as a sharp indent, we still call it as an uncinate margin, or you can call it as superior mesenteric artery surface. I prefer to call it as margin because it is done by the surgeon. So we have the fourth margin called the uncinate margin. Then you have the common bile duct, which has been separated. So that is also resected margin by the surgeon. So you have a common bile duct edge margin, we say, because it's not the whole of the duct which comes, it's the edge section which we take. So we call it as the common bile duct edge margin. So these are the margins we take. Then we take two surfaces. If you take anterior pancreatic surface and the posterior pancreatic surface just as a circumferential surface. It is not anything, there is any borders. You just take it as a shaped surface of the whole of the circumference of the pancreas, anterior and posterior. The another margin which I've missed is the vascular groove, which is nothing but an area between the uncinate process and the neck of the pancreas. You have a vascular groove which is created by the superior mesenteric vein. Now, why do you call this as a margin is nothing but it is a one which is created like a groove by the superior mesenteric vein which is going. So during the dissection process, this area is very important because the surgeon, when they're removing the superior mesenteric vein, if there is some kind of infiltration to this area, they have to submit it en bloc, and so that we do the dissection of superior mesenteric vein and we should submit. So I go to the back, two surfaces, anterior pancreatic surface and posterior pancreatic surface, and you have 6 margins: proximal resected margin, distal resected margin, pancreatic neck margin, common bile duct margin, uncinate margin, and medial groove margins, the 6 margins. Lymph node peeling, wherever the lymph nodes, whichever area, if it is around the choledochal or the common bile duct, pericholedochal lymph nodes. So on the anterior pancreatic surface, anterior pancreatic lymph nodes, posterior pancreatic surface, posterior pancreatic lymph nodes, gastric lymph nodes on the lesser curvature, greater curvature, you write the name and you write them as lymph nodes. And you have an area on the anterior pancreatic, gastric pancreatic region. That region you say is anterior gastric duodenal area, where you can have the lot of lymph nodes because that is a fat area which is being present. So wherever you keep peeling it on the surface so that you get the lymph nodes, and write depending upon the area. And please do the lymph node dissection before you actually cause the fixation of the specimen. And fixation of the specimen is usually 24 hours. If it is an HIV retropositive, it is usually 48 hours. Finish the terminology is the difficult part. I hope it was clear. Then coming to as such, the stomach grossing, we usually do the cutting open of the stomach from the greater curvature, and we follow the Tata Memorial Hospital grossing technique for this. Most of our grossing techniques in India are being followed from the Tata Memorial Hospital, which has a big bunch of very extensive way of dealing with grossing technology, and we have a book for it. And so we all Indians follow the Tata Memorial usually. After that, how do you have peeled the lymph nodes, you have the specimen, very good. Now, how do you do the paint? We would love to make it more colorful so we know which area we are doing the paint. There is no hard and fast rule of which surface is which color. So individual departments or individual hospitals have their own colors. I have a color coding system which has been just written in our department, where we fix to one area, one color. So you can use any colors for anterior surface so that, don't mix the colors. Usually I take all the primary colors for the surfaces. The secondary colors will go for the margins, which I try to inculcate my son's primary knowledge into my grossing techniques. So initially this was a case, my first case, which I didn't use any of the colors. I just had a black Indian ink color where I just painted the pancreatic region I just left. This was a case of pylorus. This was a classical, all our cases were classical Whipple's procedure. We had never done any case of pylorus preserving case. So we had only one ink. So we just used the first case with the black ink over here. Later on, I went to a little more colorful using 3 inks. Where I used yellow for that of pancreatic neck region. This was very interesting. Pancreatic neck is very, very easy to identify. And one interesting point which I learned from my professor, Dr. Michelle ma'am, is that I usually very, very hard to find common bile duct, because if the surgeon doesn't tie a loop over there, I keep searching everywhere where it is. But what she told us, wherever you see the neck of the pancreas, search very close to it, you will find a common bile duct over there. That's what she gave me a clue. Usually the neck of the pancreas, once you give shape of it, you can see the pancreatic duct. It's very easy to find. The shape part, you see a pancreatic duct. But to find a common bile duct, unless your surgeon has tied the knot, and it's a very big bile duct, so you should find it. And you can't miss it also. So if he doesn't tie it properly, or it's just underneath or been dug in by the malignancy, it's very difficult to find it. So I always have this idea that wherever the neck is being chopped, I just see just towards it or towards the lateral part of it, where I definitely find this common bile duct, and I see that I tie a thread to it so that I don't miss it after fixation. So I make it a point like that. This is another gross specimen of another third case. And this was a fourth case for us, where we had a wonderful pancreas over here, and we had a very, very, very close tumor tissue gray white area in the duodenum extending up to the pancreatic head. So this was our fourth case. This was a fifth case, which looked very, very subtle, but we had a small tumor which was in the last part of the duodenum, very close to the pancreas. Once we opened, we just found a very small, around 1 centimeter to 1.5 centimeter tumor tissue over there. So another extensive crossing. This is how we give this. I just gave a small picture. We give a axial skeletal section throughout the specimen, and we keep it in an order, just like you do a radical prostatectomy where you put it in order. We put it in order and take a picture and then note the parts of it. This I did it for the last case. The first 4 cases, I didn't have that much expertise, but by the time I touched the 5th case, I said, okay, let's do it like this. This were the microscopic pictures of all my 5 cases. This was a case of well-differentiated adenocarcinoma of the duodenum, showing us a very, very classical picture infiltrating into the into the muscularis mucosae. Different kinds of pictures, very close back-to-back arrangement, increased hyperchromatic nucleus, and increased N/C ratio. One of the cases had fully differentiated carcinoma, very malignant and very hyperchromatic, and not much of the glandular formation and infiltrating. This was another well-differentiated adenocarcinoma. This was one of the metastatic feature where we had a lymph node, pericholedocal lymph node, where we had a deposit of tumor in the lymph nodes. So one of the lymph nodes showing the deposits. So I just have a conclusion coming back. Didn't want to drag you for the before lunch. Whipple's procedure is a very complicated procedure. What is so important about it is your grossing techniques. Your grossing techniques should be absolute, and I make it a point to have the picture of the grossing technique in the histopathology report, so that the clinician also knows from which part we have taken the slide and from which part you're expecting. Tomorrow, when they have a review of our slides, they have to know which slide we are giving them also. The next part is your CAP protocol, which we usually follow in India. We try to tell which area we've involved. The trouble comes when it is an intraampullary tumor. Especially intraampullary, we don't know whether it is duodenal, whether it is pancreatic. There is a trouble making. So for that cases, we try to keep it as simple, and we have a doubt about reporting, we include a question mark. So that we are also not pretty sure about it because we don't have IHC markers also. So we put a question mark and leave it over there so that it keeps continuing to the next marathon who is taking the wagon so that they can prove it. So we leave it there. So thought of doing this case because I wanted to emphasize both on grossing techniques and the pathological features and the CAP protocol putting together to come to a conclusion of this lesion, and also to give an importance about lymph node sampling. Please do the lymph node sampling always before you fix it or before even you do the grossing, preferably. So I always do lymph node peeling before even fixation, check off all the peeling and put it in a different boxes and then do the fixation. That's how I prefer, so that none of my lymph nodes have been missed, as I always feel. Those are my references. Any questions? I thought I just make it a little short before lunch. Yes, sir.
Is it mandatory to separate each area lymph nodes?
Yes, preferably, yes, because there is a column in AJCC which says peripancreatic soft tissue. So preferably, yes, if you can separate it according to the area, that gives a better survival and prognostic lymph node, whichever is involved to the clinician. So yes, preferably yes, according to AJCC guidelines.
Okay.
Their answer.
Thank you.
Thanks so much. Thank you. Thank you for your patience. Thank you. Okay. Thank you, ma'am. Thank you so much. It's okay, ma'am. I had a first review. Yeah. Thank you. Thank you so much.
Now it's time for lunch.
Thank you, Priya. All the markets are transition. All the surfaces constantly on. We go into the this. Yes. Yes.
Not going to down, sir, in Jim Harder.
If you can just disconnect me from the screen.
Yeah.
Right.
I will do this videos.
Just wanted to ask you about the third and fourth day. It's just online.
Yeah.
There is no in person.
Yeah.
Right. And they will be recorded.
Yeah.
You
Like
can access them and all these lectures as well. Yeah. Perfect. Yeah. So we're gonna find them on the website.
Yeah. I need to just. Okay.